We'll go ahead and call the meeting to order. Good morning. If I can ask, thank you for being here as part of our Healthcare Affordability Board meeting today. Appreciate that we have a full room and know that others are participating online, so appreciate your continued engagement with us. I will ask for the roll to be called, please.
Good morning, Dr. Sandra Hernandez.
Good morning, President.
Secretary Kim Johnson.
Here.
Richard Kroenig.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan. Don Molds. 5 present, 2 absent.
And we have a quorum. Director Landsberg, I will turn it over to you.
Thank you very much, Madam Secretary. So I'm going to start with today's agenda. So following executive updates and approval of the April meeting minutes, we will take the agenda slightly out of order, with the first item being a cost-reducing strategy presentation from our guests at Providence. We look forward to that. Then we'll present OCA's recommended slate of new members to the advisory committee, followed by a board vote on that. And then we have a number of discussion items, a status update and comments regarding the data submission enforcement draft regulations, an introduction to an equity adjustment and quality adjustment to the spending targets. We have a continued discussion about spending target penalties, and then we'll end the day with an introduction to the cost and market impact review regulatory text. In terms of my executive updates, moving on to that, some of you may have heard that as part of this administration's deep commitment to affordability, Secretary Johnson and I were with Governor Newsom the Friday before Mother's Day to announce the beginning this summer that newborn babies delivered in a participating California hospital will receive 40 diapers at no cost to the family. 400, what did I say, 40? 400, 40 diapers would just get you a couple of days. Corrected by a wonderful grandmother here. 400 diapers, 2 boxes to get the family started. And we know that diaper affordability is a real problem for families. It costs more than $1,000 in a year for families to afford diapers for their baby. It causes stress to parents. We want to keep infants healthy. And families focusing on what they should be the first years, the first months and years of life by giving that help. So we know that there are families who go without other needed necessities because of the cost of diapers. We will be focusing on diapers that have the most Medi-Cal births, and are excited to that HCI did the work to negotiate that contract. As folks I'm sure know, earlier this month, the governor released the May revision of the state budget, which reflects a stronger fiscal position for the state than expected earlier this year. And the balanced budget now comes in at $349 billion. I won't go through each HCI program with the May revision, but I'll talk about a couple of highlights. The May revision does include sustainable ongoing funding for the HPD, the Healthcare Payments Data Program, California's all-payer claims database. There's also a proposal to provide support to distressed hospitals. So I think we've had an interesting view at HCI with the work that OCA and this board has done to see that some hospitals are charging much higher costs. And at the other end, we do have some small and rural hospitals, many of them that are financially struggling. So there was action taken by the legislature and signed just a couple of weeks ago by the governor, AB 108, provided $25 million in a distressed hospital small grant, kind of an emergency grant program. HCI is administering that. We received 11 applications from hospitals and hope to make awards by the end of this week or early next week. The budget also proposes an additional $50 million to provide support to hospitals in acute financial distress. And we're in discussions with the legislature about that, as well as other components of the budget. The May revision also provides significant funding to implement Proposition 1's behavioral health system transformation and work led by Secretary Johnson. We're very excited about the promise with behavioral health transformation, number of components administered by our colleagues at Department of Healthcare Services, Department of Public Health, and others. And then HCI receives 3% of the funding to support the behavioral health workforce, which we're very pleased to be able to do. The last piece that I want to mention, I think we have a slide for that, is folks may know that Elizabeth Mitchell has her last board meeting today with us. And so I just want to spend a minute reflecting. So I have some notes about your bio. I think folks know you've had a really distinguished career as the head of the purchaser business. I always want to say Pacific, the Purchaser Business Group, formerly known as the Pacific Business Group on Health, now the Purchaser Business Group on Health. But when I think about the journey that you've been with us on for the last 3+ years, and your willingness to step forward and be part of this board, and you were, you'll always be an inaugural board member of California's Healthcare Affordability Board, appointed by Governor Newsom alongside Sandra Hernandez, David Carlisle, and Rick Kroenig. And there are a couple of pictures from your confirmation hearing. That was a wonderful day that I enjoyed spending with the four of you. And as you met with members of the Senate and talked about your career, talked about your commitment to affordability, and that we know has always been your guidepost here. And I remember senators asking you questions about sort of what is OCA's role, and you've always said, I have faith in healthcare executives to make decisions. There are a number of levers that they can pull. We know healthcare is unaffordable. You have seen that trajectory over decades in your career committed to healthcare affordability. And so I really want to appreciate always your commitment to consumer healthcare affordability, and you always believing that there are decisions. We know we have a 25% problem. We know there are a number of solutions, and you've pushed us to be better and brought data forth. And so thank you so much for your partnership and your commitment to this work.
I will just pile on appreciation. I wasn't inaugural, but in my time here, I just so appreciate your engagement, not only in what we're seeing in the board and the conversations and the questions you're calling as we're tackling very, very challenging decisions that we have in front of us, but also the work of the committees and all of the additional time that you have spent really committed to making sure that we have a space and are using the levers to really push on affordability across California, both as kind of the broader work Health and Human Services does, but also as a Californian. I am just deeply appreciative of your commitment to our fellow Californians in really making sure that we are leaning in wherever we can with our commitment to each and every Californian in the space that we have. So it's just been an absolute pleasure, and just thank you for your engagement and the extra time that you've been put into this work. So again, appreciate you very much.
Well, since I do have a microphone, I have just a couple of thoughts. First of all, thank you. Thank you to the staff. I continue to believe this is the most important topic of our time. And I believe we have the best legislation in the country that gives us the best chance of success. The staff has been extraordinarily committed and tenacious, which is what is required. And my board colleagues are just exceptional. And the level of integrity and commitment that they bring to this, I'm honored to be among them. But I just really want to thank the real heroes of this process, which I believe are the people who took time off of work, the citizens who are impacted, who came here time after time to tell us the real stories of what happens when we do not act. And we owe them our best effort. And I'm not trying to be negative, but I hope the industry will take their voices into account and stop telling us this isn't doable. Stop telling us if we put a limit on them, the sky will fall, everything will close down. We have to be better than that. We have to be more creative. We have to actually collectively tackle this problem. And we have seen examples that work. We're going to hear from Providence today. We heard from Memorial Care. We know it's possible. It is a matter of will and leadership. And I continue to have faith in those leaders, and I hope they will step up and take this seriously. My two more wish list items, and I'll stop talking. One, I really hope we achieve our commitment to investing in primary care. I think that has enormous potential to improve health and reduce costs. So I'm so excited about that work. We will stay very engaged in that. And I believe we have an opportunity to look at safety and quality in hospitals. We have unsafe hospitals. I unfortunately experienced that on behalf of my daughter. And what the intersection is that her hospitalization, which should have been maybe $100,000, ended up being, I'm sure, over $1 million because of hospital safety errors and quality errors. We need to double down and hold hospitals accountable for quality and safety. Kim, I'm hoping we can have an offline conversation about what agencies can do that, because there is such a win-win there. Better care equals lower cost. So I'm so optimistic that we can get there. And I just thank you for the opportunity. Thank you for the work. I will be cheering you on and continuing to help in any way I can. Thank you.
Thank you, Director Landsberg. I'll start my executive update today by following up on an item from the last board meeting. During the April 2026 board meeting, OCA provided an overview of hospital financials from fiscal year 2022 and 2023. Several board members asked whether the 2022 financials were an aberration and requested a longer time series, which can be seen on the table on the slide. This table now also includes data for 2019, 2020, and 2021. It shows non-operating revenue ranging from 3.7 billion to 9.1 billion, profits ranging from 6.9 billion to 12.3 billion, and total margins in terms of a percentage being 5.8 to 9.6%. And then I just have one article to cover before we have discussion. OCA staff recently published a health affairs forefront article highlighting how commercial total medical expense data can help identify where spending growth is concentrated and how those trends connect to state affordability policies. So in this health affairs piece, we took data for 3 years. So the data that we've been collecting from payers. So this is from 2022 to 2024. Commercial TME per member per year increased 15.8% from roughly 6,500 to 7,500. Growth was concentrated in capitation, hospital outpatient services, and gross retail pharmacy, together accounting for about 80% of the increase. So the article connects these spending trends to 3 areas of policy focus within HCI/OCA. The first is encouraging population-based payments linked to quality. So that's with our APM adoption goals, holding hospitals accountable through specific targets for high-cost hospitals, and supporting prescription drug affordability efforts through initiatives such as CalRx. The key takeaway is that by linking measured cost drivers to specific policies, the spending data OCA collects can help identify where targeted interventions are most likely to improve value and manage costs in the commercial market. And then lastly, just a reminder about our slide formatting key for the board and members of the public. So we use a yellow area for presentation areas for which OCA has a decision-making authority. We use these public meetings to get input and engage with board members and the public. For areas where the board has ultimate decision-making authority, we note it with the green arrow. So before opening it up for discussion, just want to provide an update related to OCA's reporting. The baseline or for this year's report on healthcare spending trends, which cover calendar years 2023 and 2024. The report will be coming out at a later time, not at next month's board meeting, but later this summer. This is essentially, and then the second report we have, which is our health system performance report. So you'll recall that we're now collecting alternative payment model and primary care spending data, which was the first time we collected it this past September for covering the periods 2023 and 2024. So that report will be also we're also working on that report, and it's slated to be published early this fall. So now I'll turn it back to the chair.
Thank you very much for that follow-up and those updates. Any questions from the board? Seeing none, we will go ahead and invite public comment on the executive updates.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items to the general public comment period at the end of the meeting. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room can line up at the podium. Those attending virtually should click the raise hand button. Those dialing in can press *5 to raise your hand. We also invite you to provide written comment at the email address on today's posted agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on today's meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel, Health Access California. We want to join the board and others in thanking Elizabeth Mitchell for her service, and to say that we too have shared, and it was a pleasant surprise to us that it was across purchasers, both individual consumers and large employers, as well as other purchasers, the faith that we can improve outcomes, improve equity while reducing costs. And clearly hospital safety is part of that. And we remind the board and staff that we had talked about, including the CDPH efforts to increase hospital safety as part of the measures that are used for measuring hospitals. Hospitals in California have made real progress over the last 20 or 25 years, but there's lots more to be done. And a hospital bill that turns from $100,000 to $1 million is a good example of bad care that's really expensive. Most of us prefer not to get health care at all. We prefer to be healthy. And going to the hospital is never fun, and it's worse when you get worse, not better. A couple of other points with respect to the executive update. With respect to the May revise, we were very pleased to see that DHCS is now projecting that instead of almost 3.5 million people losing coverage because of H.R. 1, it's closer to 1 million people. That's a tribute to their work trying to implement and automate the many requirements of H.R. 1, particularly work requirements. It also has direct bearing on the work that we're doing here, because if happily there are fewer uninsured, there's less reason for hospitals and others to talk about the impact of the uninsured, because they'll have coverage, which is what we all share the goal of. We'd also like to express our gratitude to the governor for finding a little more money for Covered California. That first chunk made a big difference, and the next another $110 million. We think we can help 500,000 people get covered and stay covered, which is great.
2 minutes.
And conversely, we are disappointed to see that lawful immigrants, people on immigrant visas, humanitarian visas, refugees, asylees, victims of domestic violence in their own country will be denied coverage, breaking a promise that in California has been kept since at least the 1990s and perhaps the 1980s. So for us, that's we were disappointed about that. We're also pleased that there is some money set aside for distressed hospitals, and we appreciate the staff's analysis, the 5-year look at hospital finances, because we recognize the year-to-year volatility in hospital finances. Thank you.
Thank you. Looking virtually, I see 2 hands raised. Jane Thomason, you should be unmuted on our end. You'll need to unmute on yours. Go ahead.
Hi, Jane Thomason with the California Nurses Association. Want to say that we appreciate the work that OCA does to monitor and measure issues around healthcare affordability in California. This is an issue that is impacting Californians more and more. Recent polls show that healthcare affordability is actually a major concern for most Californians, and the situation is only going to worsen due to HR1 cuts, which has been well recognized. With respect to the article that was just presented, we think it is also important to reiterate the Healthy California for All Commission's work on these issues. As many of you all know well, the Commission's analytical report made clear that guaranteeing healthcare to all Californians through a direct payments model of unified financing, otherwise known as a single payer system, would capture billions in savings in administrative expenditures alone while lowering total healthcare expenditures in the aggregate. This remains true even when the system includes no cost sharing for patients and the expansion of long-term services and supports to all Californians. Now more than ever is the time for California to move towards a single payer system like CalCare. Thank you.
Thank you. Looking back to the podium, go ahead.
Members of the board, staff, Steve McDougall with CFT, a union of educators and classified professionals. Is this thing on? Thank you. Couple of things. Member Mitchell's farewell comments are spot on. The folks, the team that we have back in Monterey County, we often unpack the comments that you all as board members who are very skilled, very learned, and put the words together that we can't manage for us. And Elizabeth has had no shortage of unpacking her comments for meetings with our team. And today is no exception, and you will be missed. Thank you for your work in this space. And thank you for uplifting the heroes, the stories out there. It is pretty astounding when we can put faces and names to what's happening out there. And speaking of what's happening out there, I received a letter writing campaign from union members, CFT union members in the Santa Cruz area. You may recall that Santa Cruz has one of the 7 hospitals. The current year, their plan year actually starts, their rates start on October 1 for the plan that these teachers are in. The current year for the particular group was 19% increase for the year that's ending here at the end of September. But next year, starting on October 1, is slated to be 22.6% increase. And yet, we can't seem to manage this runaway train. Some folks think we shouldn't manage this runaway train. But I do know this, quality does matter, because one of the 7 can't manage to crack above a 3 on a CMS rating, year in and year out. So what are we doing? It's time to look in the mirror and get on board of reining in what's just stripping away wages and salaries. It's getting to the point where folks are working for healthcare benefits and not much else. Thank you for listening.
Thank you. Looking back virtually, Daisy, I see your hand raised. Go ahead. Daisy, we can't hear you yet. You're unmuted on our end. You might need to unmute on yours. It's in the top right-hand corner of the screen. Daisy, we'll come back around. I'll move to the person at the podium and I'll come back to you in just a moment. To the podium, go ahead.
Good morning. I'm Victoria Valencia from the California Hospital Association. Thank you to the office for responding to the board's request for a longer look back period on the hospital financial trends. The broader historical context is very helpful and gives a more complete picture of the financial environment of hospitals. One important takeaway from these statewide data is the clear downward trend in operating margins over time. As shown in the data, expense growth has consistently outpaced revenue growth across this period, making it increasingly difficult for many hospitals to maintain operations under the current conditions. I also want to highlight why this longer look back period matters. At the prior board meeting, the focus on just 22 and 23 created the appearance of a dramatic rebound in hospital profitability. But with the additional historical context now provided, we can see that 2022 was itself an unusual year and somewhat of an outlier. It's also important to remember that the statewide averages can mask substantial variation underneath the surface. While aggregate figures may appear stable, many individual hospitals continue to face serious financial challenges. In fact, 44% of hospitals operated at a loss in 2024. Finally, on the health affairs study presented today, we would encourage caution in interpreting the commercial spending figures in isolation. The office is presenting commercial total medical expenditure growth outside of the context of the broader total healthcare expenditure report, which we have not seen for 2023 to 2024. We do not see Medi-Cal trends, Medicare trends, growth across payers, or growth by provider group, or variation in geographic trends. That broader context is essential to understanding what is truly driving healthcare spending growth and where financial pressures exist across the system. Thank you.
Thank you. Looking back virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item.
Thank you very much. I also want to acknowledge that board members, Dr. Richard Han, as well as Don Moltz, have joined us this morning. So thank you for those public comments. We will move to item 3. Deputy Director?
We just have the meeting minutes and public comment received since the last meeting. And they've been circulated.
Thank you very much. Is there a motion to approve our action consent item number 3 meeting minutes?
Move approval.
Second?
Second.
We'll open it up for public comment.
We'll now take public comment on this agenda item. Please step to the podium or raise your hand. Seeing no one at the podium and no hands raised virtually, that concludes public comment on this item.
Thank you. And if we can do a roll call vote, please.
Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
That's 6 in favor. Motion passes.
Thank you very much. We are going to move on out of order. We're going to take item 5. We're going to move on to our informational items. And we'll start with item 5A, the cost reducing strategy presentation with Providence. I will welcome Assistant Deputy Director Margarita Brandt to introduce our guests.
Good morning. Thank you. And today we're joined by leaders from Providence, California to present on key strategies that they implemented to balance agency or contract labor costs with overall workforce stability, including retention and recruitment, along with some other key strategies. So Laureen Driscoll serves as the chief executive and is responsible for the performance of Providence 9.3 billion integrated delivery system across California. Daniel Kelly, Chief Nursing Officer, is accountable for strategy and driving the implementation of best practices across nursing functions in California. And Nicholas Burchell is the Senior Government Affairs Officer. And I will now turn it over to Laureen and the team to kick us off. Thank you very much for joining us.
Good morning. Thank you for having us. We're very excited to be able to share some of the work that we've been doing at Providence that I think aligns very nicely with the goals of HCI and OCA in reducing cost of healthcare through cultural transformation. I appreciate Elizabeth's comments around quality of care being really the pinnacle of culture and also the importance of leadership. So I'm excited to share the great work of my colleague Dan as our clinical leader. I'm sure you'll hear his passion, but as a nurse myself, very excited to be able to share the work that we've been able to do at Providence. So I oversee Providence for all of California. You'll see our expansive geography. I oversee the operations all the way from the Redwoods up in Humboldt County to our Orange County facilities, and we have a smattering in between in LA. So we have a very large presence and a very diverse presence. So we have everything from tertiary, quaternary care facilities in urban settings that compete with some of our academic medical centers to very rural critical access and facilities where really there is no other care provider. And that is part of who we are as an organization and our mission to serve all, especially the poor and vulnerable, which I think really also differentiates us as a care provider in the state of California, aligning with the passions of many that have spoken today. So I'll just give you a brief overview on the next slide of kind of who we are and how many patients we serve. So we have 17 acute care hospitals, multiple clinics, ambulatory surgery centers, urgent care platform. We have about 40,000 caregivers. Sorry, that was the wrong number pulled. But we have relationships with physicians, both in our medical foundations, but we rely very heavily on affiliated physician groups that partner with us to provide care across the continuum. We see lots of patients in various settings, from home, virtual, and we have a very large value-based care membership. So I heard the talking about capitation and really taking accountability for the total cost of care in a patient population. And we are doing that pretty robustly within California as well. So as you all know, there are many cost drivers that are external and outside of our control. Dan and I have been in our roles for about 4 years here in Providence. We both were previously out of state, but really what we focused on are what are the things within our control. So I heard talk about there are many levers that you can pull to be able to reduce cost. And while there are external drivers, and some of them are quite terrifying, like HR1, we really try to focus on the fundamentals and the things that are within our control, and the end result being our outcomes in patient care quality and being the best place to work and practice medicine. So lots of things that impact us in our ability to have a strong margin and to face some of the very complex costs that we have over the next several years around seismic and other capital burdens in our very old facilities. But a lot of them have to do with some of the challenges we have in underpayments and denials. For instance, the processes of getting and receiving payments has become extremely cumbersome, and has the amount of touches in manual claim work has really increased, and that increases the administrative and cost burden on us to be able to receive payments and then be able to reinvest in our communities. Increasing days of AR, so cash and claims becoming old. Many are moving beyond the 90-day period of time, and it's really hard to recapture those. Along with the increasing pharmaceutical costs, we heard a little bit about that today, but the spend year over year and the reimbursement is not following for some of these really innovative treatments to help patients on their medical journeys. And of course, the increasing pressure on professional fees. And when I think about this bucket, it really is, there's increased pressure in our providers and the revenue that they're able to generate, then that is passed on to the hospital. So these are things like call coverage pay, our hospital-based services for anesthesia, radiology, those physicians and those groups who used to be able to maintain their own professional practice in groups and pay their costs are no longer able to do that. So they have to pass their costs to the hospitals. And we are seeing double and triple digit subsidies and stipends needing to be able to keep them whole and solvent. And as hospitals, we don't have much choice because we need those services to be able to provide care to the communities. So lots of things that are outside of our control, and we would love to engage and help this group on how do we address those as a state and nation. But we're going to focus on the things that we did within our control, but just wanted to give you a little sense of the landscape of what we're facing. So some of the cost control measures that we really focused on were core operations and operational improvements. So we're going to talk a little bit more about really reducing our agency spend over the last 3 years, which really got out of control in the COVID years for many of our healthcare facilities. Focusing on length of stay and improving our reductions in length of stay, while at the same time making sure that we're not having spikes in readmission rates and that patients are safer outside of the hospital, and making sure that we're really preparing patients to both come in to the hospital, but also on their journey to external hospital facilities or hospitals at home or home care. And so we've had a tremendous focus on that to be best in class in that space. And really that reduces both our costs, but it also improves quality and care for patients. And then medical supply inflation, really reducing the amount of variation, making sure that while clinical products need to be safe for patients, making sure we're not using excess utilization. Are there opportunities where we can recycle products like pulse oximeters and different things like that? We've really done a lot of investment in standardizing our supply costs and also focusing on utilization. And then programmatic improvements. So really moving patients to the right locations for care to reduce cost. So we've had growth in some of our high acuity services where there's always a need for hospitals and high acuity care, making sure that we're able to facilitate those services, but then moving things out of the hospital to an ambulatory setting that don't need to be in the higher cost infrastructure. Changing our payment models and our funding sources. We've been looking at how do we increase our value-based care and our capitation? How are we partnering with our payers and also looking at getting reimbursed for quality? So not only about rate increase, but also making sure that we're getting paid for quality outcomes. So partnering with them in a different way has been a journey over the last several years for us too. And then strategic realignment of care to meet the needs of the community. This happens in multiple ways. There are some that we have done that have are very public, but like in our Orange County hospitals, we have 3 hospitals that are geographically very close to each other. So we consolidated like where patients might have pituitary tumor surgery, where patients may have some of the higher cost cardiac mitral valve surgery, so that patients, they're not replicating and duplicating services at all 3 of those hospitals in close proximity, but making sure patients are receiving that care close to home in their community, but also reducing the cost on that community. We have had to make some difficult decisions like not doing cardiac surgery in Humboldt County, but ensuring that patients have access to care either through our other facilities or in partnership with others. But we were doing less than 40 a year, and that becomes a quality and safety issue as well. But those are difficult decisions. So it ranges in how we've done that, but we've looked at it in the tertiary setting and in the rural and community settings. Reimagining our partnerships. We have announced our divestiture of Queen of the Valley and our intention to transition ownership to North Bay. We've had the courage to recognize we might not be the best ones to operate facilities in some of the communities we serve going forward. We can't afford all of the cost and some of the seismic that is coming with our facilities. So we've had to really look at our portfolio of where we serve and are there others in better position to do that? And so we strongly feel that North Bay is an aligned
partner that has a great mission and dedication to the community and will be able to serve that market in going into the future and is able to reinvest and commit to the seismic burdens of that facility. And so we're excited about how we do that. We've also partnered in a different way in post-acute, where we have a 50-50 joint venture with Compassus, which has actually allowed us to expand access to home and community care services and palliative care and hospice. So increasing our footprint of access through partnership. And then just really looking at our physical assets. We have recently announced that once our obligation to provide acute care facility services in Laguna Beach, that we intend to transform that facility into an ambulatory platform. It no longer, that community no longer needs the acute care services. And it has our Mission Viejo facility just adjacent to that community. And we are working with the community to ensure that they still have access to care that they need. So through an advanced urgent care, imaging, ambulatory services, but the acute facility, the facility itself is a 300 bed hospital and the average daily census is 26 and the seismic burden is $310 million for that facility. So there's no way to pencil that to work. And so the other piece is I've talked about contract negotiations and that's with payers. And then remediation of our payer degradation. So we've been able to work more closely with payers to reduce some of that administrative burden. But it's like one paying contract at a time, so it's very slow and cumbersome. This is just to look at our agency cost and the industry challenges. As you can see, this isn't our particular agency cost. This is just a cited document. But as you can see, the expense of contract labor has increased dramatically. And then we are also faced with the national shortage of qualified healthcare professionals. And it really has created this need for hospitals to rely on expensive agency and to make sure they're able to fill patient care needs, which we saw really pushed during the pandemic. And the cost of agency is much more than the cost to employ our own teams. And it doesn't feel good. Like as a bedside nurse, it never felt good for me to work hard and have the same care load, the same patient load. And the nurse next to me was getting paid twice as much as I was because they were an agency nurse and they were not ingrained in the culture or passionate about the care of patients or the mission of the hospital or the team. They were there for a period of time to do a role, and that never felt good to me as a nurse, and I'm sure it doesn't feel good to others. And so really, how do we flip that? And we'll talk about how we did that at Providence so that we can reinvest in our own teams and not spend that cost on agency labor. So I'm going to turn it over to my colleague, Dan, who's going to talk about this really isn't it. We're here to talk about our financial improvements and cost reduction, but I really want to preface it. This was a cultural transformation in our organization. It is not just based on cost. You cannot capture the hearts and minds of your team when you go in front of them and talk about cost reduction. That is not why people go into healthcare. That is not why I became a nurse. That's not why I became a healthcare leader. I want to make a difference in my patients and my communities every day. And so this really is about cultural transformation. The benefit is reducing cost. But what I really want you to take away, this is about being the best place to work and practice medicine and in a culture which is enriching and thriving the lives of our communities. So, Dan.
All right. Thank you, Lorraine. Can you hear me okay? Well, good morning, everybody. In mid-2022, this is my cheat sheet, just in case my eyes decide to fail me. In mid-2022, we got the results back from a caregiver engagement survey. And to say that they were less than favorable would be an understatement. And so at that point in time, we recognized that we did not really have the healthiest of cultures, at least one that we wanted to work within. And so in concert with my chief human resource officer, we went back and looked at 2 years of surveys, and we went through over 50,000 comments. And we were looking to see if there was anything that was threading through the surveys. And this constituted about 8 different surveys with various ends. So large groups of people, sometimes moderate sized. And so when we went back through, we discovered, as you can see up on the screen, that there were 3 common themes. So there was a lack of connection to their core leader. People were telling us, I've been here 2 years, I've never met my boss. I worked the night shift, I never see my boss. So there was this disconnect between the caregiver and leadership, which echoed, excuse me, in some other responses throughout the survey as well. And then there was a lack of career opportunity. The basic caregiver felt there was no growth for a profession at Providence. It was more aligned to a job. And if I wanted to get advanced in my career, I would have to leave the Providence system and go somewhere else to do it. So we knew we had to do something about that. And then the shocking one was that the vast majority of the people who answered the survey, I would say it was greater than 50% actually, had stated that they had planned to leave the organization within the next 1 to 2 years. So that is a forewarning of added expense, disruption, and we knew we had to develop some strategies on how we were going to tackle these primary issues. And so the first thing we did was try to connect our caregivers to their leaders. So we created what we call a stay conversation. And the stay conversation is a meeting of sorts with your leader and the caregiver, where there is about 9 questions that are filtered into the conversation. And it's make a personal connection in the beginning, because we had a lot of feedback that my boss knows nothing about me, or that, my dog just died, or my children are very, very ill. And so we were trying to build that connection. And then they ask about flight risk, and they ask about, do you plan to stay within the organization? And what about your career opportunity? Are you happy doing what you're doing now, or would you like to advance into another subspecialty in nursing within the organization? And so they entered all of the responses into a database, and we were able to pull those all together across 17 ministries and read what some of these conversations were about. And it was fascinating, because almost immediately we saw comments from the employees telling us in the subsequent survey that they had planned to leave the organization, but had they not had that conversation, they would have left. But that conversation was a deterrent, and they're reinvigorating their passion aligned to Providence Healthcare, which was really refreshing to see. So in these stay conversations, we did have to train 900 core leaders in how to do them. And the actual strategy was that for tenured employees, the core leader would have a 1 time a year conversation just to check in. How are things going? Are you happy doing what you're doing? Can we move you forward? And if you're a new hire, you would have 2 of those conversations within the first 6 months. And the reason that we did that is we had a very high turnover in the first 90 days. And we were trying to measure what is driving this. And we were able to ascertain what that was. And so these have continued. In the first year, our goal was 100%. We got to 98% because we have a lot of people on a leave of absence, and we don't disrupt them when they're on a leave of absence. So we didn't touch every employee, but we were very, very close and got some very favorable results coming back from that. So our next tactic was to look at how do we strengthen the workforce. And we have a program that is called TIPS. And TIPS is transition into professional practice. And these are graduate nurses who are transitioning from academia into clinical practice. And we have a program under the Clinical Academy that is Providence system driven. And it is an accredited orientation program for graduate nurses. And it's certified under the American Nurses Credentialing Center as a orientation program of excellence. And so every new graduate nurse that we hire gets 12 weeks orientation. You could get up to 24 weeks depending what specialty you decided to work in, because in the area of critical care or emergency nursing or surgical services, the orientation process is a little bit longer. So at this point in time, in 2022, we were not hiring a lot of TIPS. In fact, very few. because we had a very high dependency on agency nursing, and it had become the cultural acceptance that this is what we do. During our high volume periods, we will bring an agency, and when the census goes down, we will end the agency, resulting in nobody trying to recruit or trying to retain because it was just this psychological dependency on the agency. So we shifted the focus, and we developed what we call a residency program and a fellowship program. And the residency program is aligned to the new graduates, that they come out of academia into clinical practice, stay in that cohort for an entire year with the same people that they started with. That helps them build synergy and friendships and relationships. And then we created a fellowship. We heard a lot in our caregiver surveys that there is no opportunity for growth and development. So if you have been a registered nurse for minimum 1 year, you can apply to go into a fellowship. And our fellowships are designed under the same clinical academy structure as the TIPS program, to where the nurse would enter into the ICU or to the emergency department, into the surgery, and they would immerse themselves into an orientation program. They stay within that until completion of the orientation. Happy to say, since 2023, we have hired 4,550 new and moved seasonal nurses, and I think we broke it up. We did. So our fellows, again, which are the experienced nurses going into subspecialties, we moved 1,603 people into those specialties. That's an enormous number, because those 1,603 people preemptive to 2022 would be leaving to go to competing organizations for advancement in their career because we were not invested in it. And so we were able to slow down, as you will see in some of the data, the exodus. And then in the residents, we had 2,347. So this is our focus on our employee turnover. So we knew we had a problem with employees turning over, both on the 90-day and the first year. And this is where I am going to need my glasses. And when this initiative started in 2023, our turnover rate was 21.6%. That is an enormously expensive endeavor. It's about $50,000 to $60,000 to acclimate a new employee. If you look at that number compared to our total number of caregivers, it was very, very expensive. So over the course of the next 2.5 years, we really paid attention to our turnover. We saw it starting to drop almost immediately, because you could see that we launched the fellowship program, we launched the TIPS program, and we were able to pull in more employees, but we were able to keep and advance the professional opportunity and growth for the existing employees. So we put some tight controls around our work. We had a rather loosey-goosey approach to filling vacancy positions. Sometimes we had so many agency nurses working, we didn't even bother to post vacant positions because we knew we would just get an agency nurse. It was just easier. And so we knew we had to change that mindset. And so I partnered really closely with our human resources and our talent acquisition teams on developing and strengthening our hiring initiatives. And we launched into several approaches with this. We do what we call a focused hiring initiative. And so we look at hospitals that have the highest vacancy rate, and for 3 months, we dedicate a team of clinicians, administrative team, talent acquisition, and human resources to focus in on those vacancies and to close them out. And that has been extremely successful for us. Every 3 months, on average, we typically onboard about another 100 to 200 people. Interesting to note, we go back and we look at it at the end of a year. Are those same people that we hired, are they still with us? And the vast majority, the last count was around 95%, were still employed with us. So we're doing something right. And you can see where we went. We went from 21.6 down to 13.3 at the end of the first quarter. Happy to say we just got our report a week and a half ago, and we're sitting at 12.4% turnover. So we have made a significant stride in slowing down the exodus. All right, and then we were looking at our vacancy rates. This was really a tough one to tackle. We had vacancies that we didn't even know we had because they weren't bothered to be posted. Again, people had a high dependency on contract labor, and so therefore they never felt they needed to really pay attention to this. So we had to reinvent how we go about hiring people. And we increased, as I shared with you, our TIPS hiring. That's the academic entry-level nurse. And then we started focusing on our leave of absences. People would submit for a leave of absence for whatever reason. And if it was a 3-month, sometimes it would be 6 months, 7 month, 8 month, 9 month. We still hadn't heard back. So we developed a process of notifying and saying, we understand your leave is ending in the next few weeks. Your job is still here, welcoming you back. And we were able to make some inways in that. We devised a position control system. So think of it as a school bus that has 30 seats and you're running a department. You have 30 seats in your department. You get to fill them with an employee. And that's the visual that the leaders were aligned to say, okay, now I can see I have 3 empty seats. I better have 3 positions posted because we're not getting the agency that we used to get. And so we did a lot of things in this space. We had our workforce council, which is a council that meets for the South Division. We have a membership of about 30 people, including physicians and clinicians. And we look at workforce strategies, workforce cost, workforce analytics, and what we need to do to sustain and strengthen our workforce. I shared with you the focused hiring sessions. In addition to that, in the year 2023 and 2024, 4 times a year on the same day of the week at 17 hospitals, we held career fairs in our cafeterias and our lobbies, telling our caregivers that there was opportunity for them to advance their career. At the same time, if you are a Providence employee, you can enroll in Providence University and pretty much get about 85% of that tuition cost paid for as an employee. So we were really bringing that forward to tell employees that they had an opportunity to expand their professional and academic backgrounds. And then flexible staffing and scheduling, we got very creative with this. We have all types of shifts. We have 6 hours, 8 hours, 10 hours, 12 hours. That's what the workforce is kind of demanding. And then we implemented innovation and technology, which I will touch on at the very end. But again, you can see, whoops, sorry. Is that our vacancy? Yeah, that one I cannot see. When we started this initiative, we're sitting at about 10.6%. And as of the end of the first quarter, we were at 2.8% vacancy rate. So we've done a lot of work. More importantly, we have retained a lot of people over the last 2.5 years, which is decreasing the need. I'm very proud to tell you, as a chief nursing officer, I have waiting lists for nurses to work on some of the units in our ministries across the division. So publicly, it has gotten out that we invested time, strategy, inclusivity. Everybody's voice is important. We brought that into our processes, and I believe that that is what is helping us sustain some of these incredible outcomes.
Like last week, I was in our Humboldt ministry and they were sharing some of this information, the executive team with the board, and their vacancy rate in Humboldt is 3.2%. And so they were talking about there is going to become a time where they don't need, like they were not going to have enough spots to fill some of the nurses coming out of school. And so now what's the strategy? Because we actually have met the needs of that community from a staffing perspective. That was not the case several years ago. And that's a very difficult community to recruit to. But we have a wonderful partnership with the College of the Redwoods there.
Yeah. Well said. Thank you. All right. So this is the ba-ba-ba-boom slide, if you will. We had, when we began this initiative, over to the left, I've really focused on everything. These were all tactics and strategies that we aligned. But if you go to the bottom paragraph there, it actually tells you that we had saved between the 2.5-year period of time, $220 million from budget expense and contract labor. Today, which is at the end of the first quarter, our monthly agency spend is down by 76%. We are always going to have to depend on agency nurses, because when people go on a leave of absence and they have an emergency or they have an illness, we have to guarantee them their role, and we support them in that, and we will bring in temporary labor until they come back. We just tightened a little bit the length of time that people were taking it to get people back to work sooner. So if you look at 2023, we started out with 1,611 agency nurses working across our ministries. And we have that number down as of a week and a half ago to 322. I'm happy to say by the end of this month, that's going to drop to under 300. So we have really decreased our dependency on agency nurses by building programs that would advance people's professional careers by bringing in academic, freshly new mindsets in nursing. They're exciting to bring on. When we do a cohort, we do it twice a year. And in each cohort, we have anywhere between 500 to 900 nurses that we will bring in. And that's very exciting when you cast that out across 17 ministries. So we stay very connected to this part of the workforce. And I did touch on earlier the innovation, bringing innovation into the workspace. And this current generations that are coming out, many of them don't like this paper. They like this, and they like technology, and they want everything instantaneously, and they want their data sources to be reliable and dependent. And so we started bringing in technology into the workforce. So you'll see here, oh, wait a minute, that's the, I'm ahead of myself.
It's okay.
No, all right, I get carried away on this, as Lorraine told you. 2 points I want to make on this one. The targeted measures that were implemented to optimize the workforce management in partnership with our industry leaders, nursing turnover came down by 40% since that initiative. Nursing vacancies went down 86% and are holding very steady. And this we're very, very, very proud of. And I will tell you that if you look at this green box, this is the survey that I had referred to at the beginning, that we were less than favorably excited about it. But this is our 2026 second quarter survey. And under the engagement score, that's the overall engagement of the employee base, we are at 74, which was a measure above the average system score of 73. We had a response rate of 52%. We had over 12,400 comments. And most proud is the top 3 strengths that were noted in the survey. Organizational potential. I am excited about the organization's future. And this is the time where we're cutting costs and looking at what opportunities we have and divesting some of our interests. And it came back remarkably positive. And growth. I have the opportunities to learn and grow at the organization. We created all of these pathways for advancement and growth, and it really it's starting to pay off because people are moving through these orientations and they're elevating their career and they're happier, and therefore they're less inclined to leave. And then mission connection to the work, which I am extremely proud of. The work that I do at this organization is meaningful to me. These were not healthy indicators in 2022, 2021, or 2020. We did not see the shift of positivity until we had leveled out all of these tactics.
And we do the survey 3 times a year. So it's not like a one and done, and then you're really looking at data so that we can be actionable more frequently in the year. And so this is our recent one. During the 3 weeks that the survey was open, we had 2 strikes happening in 2 of our ministries, and we announced the divestiture of the Queen. And yet we still had improvement in 16 different categories, and these were the strengths of the themes.
All right, and then I jumped ahead of myself, but here we are again. So I want to touch on a little bit of technology. And again, we're very thoughtful of bringing technology in because we have what we call the Providence Promise, and that is know for me, care for me, and ease my way. And so whenever we look at technology, we want to be sure that that is aligned to our Providence mission, because right now out there in the industry, there's technology advancing so quickly. What I buy today will be extinct in a matter of 6 months because someone's going to perfect it to a higher level. But a fundamental process that we implemented is the co-caring pilot. And the co-caring pilot is a virtual nurse, and it is aligned to 2 caregivers. So there's a triad of people. There is a bedside registered nurse and a bedside licensed vocational nurse, and then there is a registered nurse who's virtual, who basically lives and works through the computer and the television. And so when you are admitted to the hospital on certain units, right now we have 4 inpatient units, 1 emergency department. Within the next week and a half, we will expand to a secondary emergency department and 2 additional inpatient units. By the end of the year, we're anticipating being close to about 400 inpatient beds being covered by virtual nursing, and probably 7 of our emergency departments. What the virtual nurse does is, so when you are admitted into the hospital, the bedside nurse will say to you, we use virtual nursing here. In a few minutes, they wait about 30 minutes to 45 minutes post-admission. You're going to hear a doorbell ring and a voice, and they will ask if they can come into your room. And if you say yes, there is a camera that will pan, and it's a high-definition camera that can really hone in from an assessment standpoint. And the virtual nurse will come on and introduce themselves. Now, in the meantime, this has freed up the bedside nurses. Remember, there were 2 of them, and we're now giving them back the gift of time to spend more time with their other patients. So we're creating sacred encounters, and we're making personal connections at a time for a patient that's probably the most vulnerable time for them. And what the virtual nurse will do is the administrative task. So she will come in and complete the admission assessment. This is in the computer. It's probably about 7 computer screens that you have to fill out. She will interview the patient and ask questions, understand their medical history, document everything. She will do what we call medication reconciliation. If you come into the hospital and you're on 5 medications and your doctor on the admission time ordered 2 additional medications, that nurse will go over all of that medication data to reconcile it and be sure everything is where it needs to be. And then they will review the diagnosis for patients in terms that they understand. So our virtual nurses have been trained, avoid medical jargon and talk in layman's terms so that the people can understand why they're here. And then at that point in time, the virtual nurse begins the discharge instruction. So really happy to say that we have seen in these virtual units a dramatic increase in our length of stay. One particular unit went from 1.21 geometric mean over expected down to a 1.0. It's a significant movement. And so patients are getting what they need, they're understanding what they need, they do teach backs. All of this is done by the virtual nurse. And in the meantime, the other nurses are able to do additional work and connection to those patients. So from the lens of what you're seeing at the bottom, this is the system. So there's right now about over 30 units across all of Providence's 51 hospitals that have the virtual nursing component. They are seeing a 50% reduction in patient falls with moderate to severe injury, which is a huge safety shift. We are seeing a 20% reduction in average patient discharge time. In Eureka, in Humboldt, they were the first emergency department to be launched in the whole entire healthcare system. What we have seen there is they have been able to shave 42 minutes off every patient's length of stay in the emergency room. Why that is so important is because that has created throughput and capacity. Because what happened is if I can shave 42 minutes off of a 30-bed emergency room and people are moving out at 42 minutes less, well, that ministry has basically eradicated any waiting time in their lobby. They also put in the physician in triage. There is a popular show on HBO. It's called The Pit. I don't know if anybody's watching it, but that's what it is. And so the physician greets you at the front door and works with the triage nurse. But because we're getting patients out sooner, we're able to bring you back. So the patient experience results on that particular ministry were the highest that they had ever seen. And so the world of technology is working with us, and we are working with it very selectively. There is another component that we launched, which is called Macros. And Macros is an Epic-based program to where it takes repetitive documentation. I have to document that I've turned my patient every 2 hours or that I've checked an IV site every 3 hours. Rather than going into the computer and doing multiple keystrokes every hour on the hour, you can hit the Macros button and it will draw from the patient's plan of care. It's AI-based and it will document all of it for you. And on July 12th, the newest technique that we're launching is referred to as Pixel. And so Pixel is a AI-based in Epic. And what it does is at the end of every shift, if you are a nurse, you have to write an end of shift summary on the day's activity. So about 2 paragraphs where a nurse has to document. Do that times 5 times. It's about a 45-minute endeavor. With Pixel, it will pull from all your documentation throughout the day, and it creates a shift summary report for you. And all you have to do as the nurse is go in and read it, and you can edit it or you can accept it as it is, but that is going to save an enormous amount of time. So through these platforms, we were able to measure from January 25 to January 26, we saved our nurses in the division 5.5 million clicks on a computer. That is an enormous amount of time. that we have untethered a nurse from a computer and given them the gift of time to go spend it with their patients, which is what they went into this profession to do.
The only thing I would add around this model is these are our caregivers. These are our nurses. They actually do some shifts, like the ER nurse will do 2 shifts in the ER, 1 shift virtual, or a combination of that. So they know their colleagues, they're part of the team. This was not an FTE reduction strategy. This was adjunctive supportive care. So this has the same number of people caring for the patient care team just in a different way, to add different layers of removing burden. It has been phenomenal. When I go and round and talk to the teams that get to do this, they love being able to have the time to spend with patients through the virtual nursing program. There have been times where a nurse would go into a room to do a check on a patient, notice a facial droop, notice a change, and call a rapid response team for a patient that was experiencing a stroke. I mean, it has just been phenomenal, the interventions that we have seen. And it's a different way of keeping critical thinking at the bedside in our aging nursing population, to be able to offer opportunities for people to not have to physically be on their feet for 12 hours or moving patients. It's a very difficult and demanding job. And so this gives them a different opportunity to remain at the bedside. So we're very excited about this. I heard mention about CMS stars. We've done all of this work while increasing. Our goal is to have all 5-star hospitals. That is our goal. And we have 2 5-star hospitals, 9 4-star hospitals in our system. And we have been moving every year, improving that journey for our patients as well. So all of this work, while it helps our financial bottom line, is not at the cost of patient care and outcomes. So we're really proud of it.
Not at all. We're also seeing an opportunity to bring nurses back into the profession. So currently we use our own employees to interchange them in some of the virtual units, but some we've been able to bring back nurses who left because the physicality of nursing, it catches up to you quickly. And so there are people who love the profession and want to stay in it, but they can't be on the floor for 12 hours. And so they have learned of this, and we're getting a lot of interest externally of bringing back retirees and even preventing people from leaving the profession. And why this is so important is, I'm sure you're all aware of the statistics, but in 2030, we're projected to be having nursing shortage of about 750,000 nurses across the U.S. And that's 4 years away. And by 2040, that's predicted to escalate to about over 2 million nurses shy in the United States. So we would not be able to sustain the care that we deliver in the current model that we're in, which is why we came forward with the co-caring virtual model to see how we can continue to provide exceptional care to the communities. So.
Thank you.
Thank you.
Thank you.
I really greatly appreciate that presentation and sharing your success, and congratulations on your success and your strategies to achieve that. I'm going to first go to board members for questions. Okay, we'll go to Richard and Ian.
Thank you so much for that presentation. I think one of the things that, as we talk about the nursing workforce, there's been some debate about whether this is really a supply problem or retention problem. In fact, I think there's a recent report showed there's actually 1 million nurses who aren't practicing right now out there. So, in fact, it's a very substantial portion. So we train a lot, but then a lot of them leave for main reasons you cited. So, so I'm really thrilled to hear. It sounds like there's actually what you're doing is investing a lot in, frankly, retention. I mean, you are recruiting, but I think retention is probably the big thing. One of the questions I did have is in terms of, just to put some context to the savings you got, what is your total revenue in your system then? So what is, 220 million reduction in agency labor? What percentage of your revenue, how much does that affect your overall revenue?
In this last year, operationally, Providence in California was still operating at a loss.
Okay.
But so it shrank that for sure and helped. But our total revenue was 8.9 billion in
Okay.
California,
Mhm.
but we have a negative operating margin. Our goal this year is to hit break even.
Okay. All right. So obviously significant.
Yeah.
And I know this isn't part of the main part of your presentation, but it's part of your initial presentation. You mentioned that those cost drivers external to your control resulted in an incremental cost of 300 million, which is actually even larger than the savings you got from reducing your agency nurses. And what seems to be particularly disturbing to me is what seems to be very substantial increases in the cost of just trying to get paid.
Yes. Yeah.
So we're
and
creating
so
a lot of friction here, and we're spending looks like there's a lot of money and time and effort just to get paid for what you're doing.
Absolutely. The number of touches on each claim, the number of red tape and administrative burden is huge. And so we've been trying to tackle that one payer contract at a time, but it's difficult.
Okay.
We're certainly trying to introduce legislation ourselves to help ease that burden.
Okay.
So I think that that's definitely something that could be a focus as we're all working to reduce other areas of cost. The administrative burden is really challenging.
Okay, I appreciate that. We've already had discussions here about, we're looking at on the plan side, how much they spend on administrative burden. We have medical loss ratio, but we also define on the provider side, when yours, like all this cost, this 300 million would be, oh, that's medical cost, but that's not really medical cost.
It's not. It's
Is
burden.
right. It's administrative burden, and this is an incremental cost. So your total cost of doing all this is just an incremental increase, is much larger.
Yeah, you're correct. That's why there's, I think this board recognizes there's many complicated facets to reducing healthcare costs. That's
Right.
going to have to take many of us to work in different ways than we do today.
Okay, so I guess I would view this as, certainly not contributing to improvement of patient care, not improving quality, something that perhaps ought to be I won't call it low-hanging fruit because it's complicated, but a tremendous opportunity to take cost out of a system without actually, I actually think it will improve the quality, the availability and quality of care if we reduce these burdens as well. I mean, this is just friction.
I agree
Right.
with you.
Thank you.
Yeah, that was helpful, and 220 million on 8 billion revenues, not insubstantial. Could you give us a sense, you talked a little about the asset divestiture of Queen and maybe other facilities. What's the scale of that going forward, and kind of a corollary to that? We saw a chart earlier showing over time across the entire hospital industry, operating income, but also net profit. And it really drove home for me what a big portion of profit investment returns are. And so I'm wondering, as you realize those sales, like what guarantees, what checks are there for the communities that that money is either going into direct patient care, or it's going to the purchasers who are bearing the costs and not going into pools that'll grow the investment base?
Absolutely. So as a not-for-profit organization, our commitment and the commitment from our system board as well, because we have a multi-state footprint, is that those dollars, once we pay off the debt, the bonds, all of the things, whatever we have left after divestiture will be reinvested in California in our ministries. And so some of that seismic cost number that you saw up there, definitely monies will be needed to be put towards achieving those seismic goals for 2030. And some of our ministries that are not currently profitable and probably won't ever be profitable because of the communities we serve, we need to be able to still keep them, because like in the high desert or in Humboldt, we are the only player in town to meet the safety care needs of patients in those communities, and we're committed to remaining there.
Elizabeth?
Thank you. I have actually two questions. One, sort of first, thank you for exemplifying the sort of leadership and innovation I was referencing to really be accountable for total cost and invest in care. One question I had was, have you seen measurable impacts on patient experience and or quality from these changes?
Yes, absolutely. I'll let Dan talk about it, but we have top decile performance in patient sepsis mortality, which is the number one, cause of death for patients in hospitals. So we are under 1. So we have phenomenal care. As I mentioned, readmission rate. We are tracking that. We also have top performance in that as well, because we don't want to be moving patients out of the hospital sooner than they're ready and then having them come back with more complications. So all of those things, and that's why we also are on a 5-star CMS journey. Really, that is the gold star of all those measures rolled up together. We also have 6 magnet hospitals, which I also believe is a forcing factor of highest quality of care. Did I miss anything? Patient experience is a journey that we're still working on. We're not where we want to be there.
We're good.
We're good.
We could be better.
But we can be better.
We have seen some significant impact with the virtual nursing platforms and patient experience. In our Mission Viejo Hospital, the patient experience went up 14 points. That's huge. Simultaneously, the caregiver engagement survey went up 42 points. So your comment about 1 million nurses out there not working, they're not out there. They're out there not working because the work intensity is so impactful that the physicality and the emotionality around nursing is very complex. And so when you can see the happiness in your patient, it does reflect onto you as a nurse and as a person, and you know that you're making a difference with it. So the virtual nursing has sort of been a little beacon of light that's come into the world of patient care, and it's really restoring a lot of the faith in nurses that were contemplating leaving because they can't take this anymore. And people don't understand it. When you're taking care of 5 patients and you have 2 that have to be discharged that day, and then you have a death of a patient, and then you have to go into a room and be happy, because it's very, very hard. And sometimes the emotional toll is more taxing than the physical toll. But where I'm most proud with this is we have seen and sustained some incredible quality results. So when we look at CODIs and CLABSIs and HAPIs, and we look at all of the quality indices that we measure, we are green, top of the tier in all of them. And it's just really, that's what I give back to the nurses in their work. You did this. This is what you're doing. You are keeping people much safer today than we did 10 years ago. And it's evident there. And so when we see some of the comments coming back from our patients who had a virtual nurse, I hear everything from, I love the nurse in the box. I love my TV nurse. I hope to see her again. I mean, I thought that was a very comical, I think the patient actually thought maybe this was like a TV show. But it's yielding a lot of positivity. And that's what we really needed at a time where it can be kind of dark.
This is brief, but I was building on Dr. Pan's question when you highlighted the need for changes in payment models, and you talked about having to decide not to deliver some services. And in some places you keep services because they subsidize others. It's not rational or even, aligned with quality. And my question is, are you getting support and flexibility from the payers? Are they able to implement these new payment models? Because even when we talk about them, we hear a lot on the ground that we're still just doing fee for service, even when we call it value-based payment.
I would say it's a combination, and it's a little bit geographically located. Northern California is definitely still very much a fee-for-service model. There's not a ton of capitation and value-based care in Northern California. Orange County and LA is a little bit more mature, but we're even seeing increases in PMPM. You're seeing that shifts in the challenges with MA. Utilization costs are difficult to manage. So I think there's still a lot of work there to do.
Well, thank you for that presentation and for all the work that you've done. I'm curious, you didn't mention payer mix. Would you say a little bit about payer mix and how it plays into this increase in delays for claims?
We're 70, just making sure we still are. We're about 73% governmental payer mix. And so our commercial base is pretty low.
Yeah, I
And
asked
so
that.
QAF dollars and the impact on provider fee, all of those things are going to have tremendous impact to our organization that we're trying to figure out mitigation strategies.
And do you have any preliminary thoughts about how you'll manage in an HR1 environment?
That's what we're working on right now around strategies, and some of it will need to be rethinking our footprint.
I would just add as well, we are if not one of the largest providers of healthcare to the Medicaid population, every community we serve. It's very much driven by our mission, and it's why we're there, and it's where we invest our dollars to continue to be able to do that. We mentioned Humboldt, that community, obviously Northern California, but that's across our entire system, especially here in California.
Okay, we'll go to Don and then Richard.
Sorry, I'm just going to follow up on the question about capitation and value-based payment. Can you talk a little bit about the relation between some of the journey towards efficiency and cap, and do those go hand in hand? And do you see a relation between the payment model and the speed at which you move to bring in some of these efficiencies and reduced hospital stays and so forth? That's question one. And then question number two is a quick one, hopefully. But on the commercial side, do you have arrangements directly with purchasers, or are they all with payers?
Our arrangements are with payers, but we also have our own restricted Knox-Keene as well that we do. I would say in areas where we have mature and alignment with our foundation medical group and affiliate physicians, where we have really strong and multiple years of strong alignment, especially like in our Orange County market, it is much easier to move the needle on efficiency and sharing the cost of care among the larger group than it is. Hospitals are not incented to have less volume. So it's complicated. But when you can make the right choices for a group of patients, when your model is very integrated, then it's much easier to do. In the immature markets, it's much more difficult to do because aligning incentives is harder to do. So I think it's really about how we align incentives, and the goals have changed over the last several years. And so it's easier to do that when you have a more mature partnership.
Thank you.
Hopefully that helps.
Yep, that helps a lot, actually.
Thank you. I add my thanks to those of my colleagues, both for your work and for being here today. And as a former director of AHRQ, I'm just delighted to hear the focus on safety and the reduction in counties and CLABSIs. My question is about money, though. With all the wonderful work you've done, I wonder if you have, as you know, I'm sure the office and the board have been working on hospital spending targets and looking at cost per case mix adjusted admission and per adjusted outpatient visits. Do you have estimates from recent years, either 2025 or projections for 26 or 27, of what any of these metrics might look like in your system?
The case mix?
Cost per case mix adjusted admission.
I don't have those off the top of my head, but yes, we do factor that in. Yeah, when we're looking at our budgeting process, which we're about to enter now. So we are predicting like the impacts of HR1 next year and how to manage that with volumes. And we are always looking at the shifts. Our case mix index in the hospitals is actually climbing because of our work that we've moved lower acuity care out to ambulatory settings. And that's also kind of a challenge in some of our markets where we don't have a robust ambulatory presence or setting because we've been really far behind where things are mostly hospital based. Again, like in Northern California, it's harder to do that and share the dollars in a way that makes sense and not impact the revenues because we're not incentivized as hospitals to do that. And so it's a balance. So it's different per market. I know that's hard for me to explain, but we do look at those factors in all of our markets. It's very different in LA when we're competing with the academic medical centers in how we do that.
If there is any information on that you could share, that
Sure, we can have Nick follow up with you for sure.
And I think final question from the board, just two things. One, you mentioned in your kind of upskilling of existing staff as your retention strategy, some partnerships. So if there's anything else you would lift up on where you've been able to do some accelerated programming or other partnerships with higher ed or others, that would be helpful to know. And the second is around your kind of worker first technology solutions. Just anything else that you're seeing on the horizon, anything that you have now tried and tested that you also maybe think is not a solution, anything else on the tech solutions?
Yes, to answer your being tethered to a computer, sorry. Yes, so we're looking at ambient technology. And so there is a platform called DAX, D-A-X. And our providers are using this right now. And this allows you to orate your assessment and it will automatically, the computer will formulate it for you. Can actually disperse it into locations in various spreadsheets. So I have advocated and they finally agreed to bring this into the world of nursing. So we will be piloting it in 2026 in 4 hospitals to see how effective is this. Now, this has been around for a couple of years, and there are hospitals in this country that are fully 100% ambient. They have very few computers, and everything is just voice activated. And so we were able to see that it was highly efficient and very accurate. Even with accents in different dialects, it can still pick up on it and accurately document it into the medical record. So we're feeling very excited about this. We're also looking at some new technology referred to as BioButton. So if any of you have been in the hospital, you know that at midnight when they come in to take your blood pressure and you're sound asleep, you're like, why are you doing that? And then they come back at 4 a.m. and you go, why are you doing that? And then everybody has to go home to rest because you get no rest in the hospital. BioButton is about the size of this, and it is affixed, and it measures and documents all your vital signs. We do not have to interrupt you at all. We no longer have to put this cuff on you and take your pulse. And so I worry a little bit about that because the manual technical skills I don't want to disappear, and I don't want to be totally dependent on technology. I was raised to, look at the monitor as a guide, but look at the patient. And so I just want to be sure that we're doing that safely. But that is something in 2026 we'll be looking at as well.
We're doing a lot in the space for physicians as well in ambient and reducing inbox burden, things like that. We're also looking at with our virtual nursing, is there other disciplines that we can bring into that, like pharmacy, case management? So we're looking into, how do we expand that maybe beyond nursing and be innovative? We have multiple partnerships with many different schools in imaging, some of the other therapies where it's hard to recruit partnerships so that we provide training
sites for the schools and partner with them so that we can build those like OR techs where, there's more than just nursing where we have clinical shortages for sure.
But in the world of academics, so when we launched the co-caring model at Mission Viejo, the model, because of the regulatory Delegation Act under the Board of Nursing, we had to use an LVN. The original model, which was born in Lubbock, Texas at Covenant Medical Center, had a registered nurse. Remember I told you it was 3 people, registered nurse at the bedside, nurse's aide, and then the virtual nurse, because the nurse at the bedside can delegate under their Board of Nursing more than we can. So what we had to do was reach out to the LVN schools, and I'm ashamed to say 20 years ago, we pushed the LVNs away and we said we didn't need you. And so they adjusted their curriculum to not be focused on the acute care arena. And so when we reached out to them and we said we would like to start employing your LVNs, we had to partner with them and restructure some of their curriculum. And it wasn't even enough at the first pass. We're now going into year 2, so it'll get a little easier. So the onboarding of an LVN took a lot more time with added expense because they weren't academically prepared for that transition.
Thank you very much. Really, really appreciate you taking the time to be with us and sharing today. We're going to open up this item for public comment.
Thank you. We'll now take public comment on this agenda item. And please note that while the board and staff and presenters are committed to communication and transparency, we will not be responding to public comment. Additionally, they may not act or discuss any matter raised during the public comment that was not on the meeting agenda. I'll start virtually this time. Jane Thomason, I see your hand raised. Go ahead.
Hi, Jane Thomason with the California Nurses Association. I wanted to provide just a brief comment on the use of virtual nurse programs in hospitals and other healthcare settings. I think as we just heard in these virtual nurse programs, nurses typically appear on a TV screen and can only verbally interact with patients. That means that virtual nurses are not able to provide any hands-on care. They are not able to assess patients. They are only able to ask questions and interact verbally. So what that means is that for patients who are disoriented, if they have dementia or they're going through withdrawal, or for patients who are just not used to utilizing technology in this way, virtual nurses can actually increase agitation and confusion, which increases the risk of workplace violence and other safety concerns. Many virtual nurse programs incorporate AI, artificial intelligence, which also raises significant concerns around bias, false alarms, and errors. AI just cannot do what RNs do in terms of looking at a situation critically and individualizing care to the patient's needs. Also, virtual nurses in many programs often work out of state and are paid lower wages than hospital nurses. That's something that we should keep in mind when we're looking at these kinds of programs. Ultimately, virtual nurses cannot replace in-person hands-on nurses in the hospital. I also want to note that there is no nursing shortage in the United States. In California alone, there are more than 150,000 RNs currently licensed who are choosing not to work under the dangerous conditions that hospitals are creating. Employers should be improving these working conditions so that they can recruit and retain the nurses that are needed to care for patients safely, not spending money on technology that is ineffective and does not provide the same level of care. Thank you.
Thank you. To the podium, go ahead.
Beth Capel for Health Access California. Like the board members, we appreciate the presentation and the discussion. I will say, as some of the board members know, I have worked with nurses and healthcare workers since the late 1980s, and excessive registry use or agency use has always been a source of cost and instability in care that impaired outcomes. And we are pleased to see an enterprise that recognized it, hospital system that recognized that and took steps to address it, because it took a fair amount of work to do that. So we share the concerns about inappropriate use of AI, and I think no surprise that nurse leaders would think about it differently than bean counters. And I would also add, we've heard from 2 nurse leaders today. It's good to hear that they are also including other members of the team, including other aspects of professional and technical work, because As essential as nursing has always been to hospital care, it is not the only care that's provided in a hospital, whether it's imaging or pharmacy. Two other points. The requirements for seismic have been the law in California since 1994. Many hospitals, and we're impressed by HCI's data on this and appreciate the public data on this, have moved forward to compliance. And so we are pleased to see that the 2030 standards are being complied with. With respect to administrative burden, I think we discussed that at the last board meeting. I'm pleased to say that the publication of the recent UCLA report on the SBs as part of the SB 770 project updated the work of Jim Kahn and Rick Kroenig on administrative burden and provide additional and more updated insight into how much money we are wasting as a system on billing, insurance, and whatever the R part of DIR is, which Rick will remind me of. But standardizing things like coding and all of that across payers could go a long way to getting rid of wasted money. Thank you.
Thank you. Looking virtually, seeing no hands raised, I'll go back to the podium.
Good morning, Joan Allen, SCIU United Healthcare Workers. We do represent workers at 2 Providence hospitals, not for the most part the RNs that were most of the discussion today, but the allied healthcare professionals who are the rest of that care team. And want to start off, really appreciated the discussion on contract labor. Going into COVID, some of the hospitals that were the least ready to respond to COVID were the hospitals that had the highest reliance on contract labor. They saw their labor pool immediately dry up and their costs skyrocket. And so the hospitals who were more reliant on in-house staff were better able to be flexible and more responsive. And we have seen that as a dramatic cost even coming out of COVID. We really appreciated, therefore, that when OCA advanced the workforce stability standards 2 years ago, that contract labor reliance was one of the key performance indicators included, and would advise as we go back and strengthen and revisit those workforce stability standards that we find better ways to measure contract labor, because we have at least some metrics for it for RNs, but generally not for the rest of the healthcare workforce. And we know that it's critical for more than just RNs. And to that, do want to also just flag that idea of a workforce shortage for not just RNs, but across the entire healthcare pipeline. We are seeing pretty dramatic shortages in some parts of the workforce and know that we need to make improvements. Have seen the state put substantial thought and investment into the behavioral health workforce, and would just encourage that even in these tight budget times, that we really are making sure that the entire healthcare workforce pipeline is strong, because those RNs that we're going to need 10 years from now are already, for the most part, in our healthcare pipeline. But if we're not creating the growth pathways for them, then we really are going to be in a much more critical shortage. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this agenda item.
Again, thank you very much. We appreciate you being here with us. For the good of the group, I will also make sure that we are actually holding a webinar on that SB 770 report fairly soon. We'll make sure we get that out to people should they want to listen in and learn more. We are going to move back to item 4. I'm going to welcome Assistant Deputy Director CJ Howard to present a potential slate of new advisory committee members for the board to consider.
Good afternoon, or almost afternoon. My name is CJ Howard. I'm the Assistant Deputy Director of the Healthcare Spending Targets Branch within OCA. We will now present the board with the recommended slate of advisory committee members. So on the slide, we see that 16 of the 29 current advisory committee members have terms that end on June 30th, 2026. These positions are noted with the yellow star. Go to the next slide. So we have received the advisory committee submission of interest recruitment was from January 1st to March 31st of this year. We received 50 submissions in total. 13 submissions were from incumbents. 7 applicants from last year's special payer recruitment period requested their submissions to be carried over, and we received 30 new applications.
Maybe you get to this with this slide. I just, which incumbents chose to reapply and which ones didn't?
I will show you which ones we're recommending to reappoint. I don't know that I have off the top of my head, but we can find who the 13 were that resubmitted. So this slide is the recommendation from the Advisory Committee Selection Subcommittee, consisting of board members Sandra Hernandez and Ian Lewis. The subcommittee recommends reappointing 9 incumbents that are highlighted in green and appointing 5 new members that are highlighted in yellow. To balance the AC, the subcommittee recommends a special recruitment period to recruit and appoint an additional purchaser. This special recruitment period is now open until June 30th of 2026, and the submission of interest form is on OCA's website. I'll just note that Iftikhar Hussain was initially appointed to represent the purchaser category last year, but his title and association changed shortly after his appointment. I'll now turn to the subcommittee to provide any additional comments or information on their recommendation.
Thank you. Let me just say a couple words. First off, the was a particularly tricky one for me, and this is, I think, only our second round going through this, Dr. Hernandez and I.
get it.
So really appreciate our predecessors on this committee. It would have been very easy to double the advisory committee in size, but we were disciplined. I want to especially appreciate Megan Brubaker and Wayne West and the other staff who made this whole process pretty as easy as possible to navigate. To Dr. Pan's question, I believe there was one incumbent who reapplied but did not get reappointed, and that was Dr. Doherty from in the physician category. And I'll let Dr. Hernandez speak for herself, but for my part, we had this tricky balance to strike between appreciating the contributions of incumbents and the experience, and also the extraordinary strength of applicants, particularly from the physician community. And I have to say, as somebody who's we've all attended a number of advisory committee meetings, Dr. Doherty's comments really stick with me and help shape my thinking on a number of issues. I have a very deep personal appreciation. So it certainly isn't a reflection on his contributions or anything that we're not recommending he renew, but rather that we had a long list of very, very strong candidates from the physician community, and we're trying to strike that balance. I think that's all I have at this moment.
Yeah, I would echo Ian's comments and appreciate the work that staff did on this. This balance between incumbents and really strong applicants, particularly in the physician group, was something we talked a lot about, just trying to figure that out. And I would just echo that this was not a statement in any way, shape, or form about the incumbent and the physician group. It was really just trying to open it up to other perspectives. And the only other comment I would make is that in looking at the entire advisory group, it was notable that we really didn't have anybody in any way, shape, or form from the pharmacy space. And we had a very strong application from a gentleman named Sean Kim. And so we are recommending that without, again, trying to expand broadly the overall size of the group. So with that, I'm happy to take any questions from my colleagues.
Go to Ian and then to Elizabeth.
Sorry, I did forget one thing on holding open the purchaser slot for further consideration. We had a fairly limited number of applicants and that, and I think, you know, having seen somebody switch categories, I don't think it's a bad thing that we have 4 hospital representatives on the board, but just trying to balance that out, and also we thought we'd benefit from some extra time holding that position open, especially considering none of the current purchaser representatives directly represent a purchaser per se.
Yeah, if I could just add a comment about that. I think if the board has a viewpoint on the situation in which people change categories in this space, we'd be open to that because there was no real precedent for that. So if there's strong points of views, I think that would be something we should take up.
I think I have a strong point of view because there's no way a hospital representative should be representing a purchaser. And I feel I really like and admire Iftikhar and Suzanne, and I was instrumental in recruiting them, but they have changed categories. So they should not be in the purchaser bucket here. And Mercer is not a purchaser. More often than not, the consultants are paid basically by the health plans. So I just think it's like, I'm not even suggesting you don't have them on the advisory committee, but they should not be purchaser representatives. They're just not. And so I did get an email about the vacancy and recruitment. We're sending it out to our networks. So we're happy to try to help, but I just feel very strongly that, again, keep them on there. They're great, but not as purchasers.
We'll go to Don and then Richard.
I would just second Elizabeth's point of view about purchasers and consultants. I also think very highly of Suzanne. She was a purchaser at an earlier point in her career and was exceptionally innovative. I'm sure she's a terrific consultant as well, but she's in a very different role. And the consultants in those firms serve payers and others and hospitals. They have multiple points of view, and a purchaser view is one of them, and sometimes in conflict. Forgive me for saying that with the other ones.
Well, I guess that leads to several questions that I have about the proposed appointments. So first, I guess in terms of the purchaser issue, since we're on that right now, so what I'm hearing is that there's an opinion that Suzanne Usage from Mercer is not really a purchaser. Okay, so but
She was when we initially appointed her. She was at the one.
Right, but she's still on the recommended slate. That's why I'm curious. Like, okay, because I understand her term is out. That's why she has a star, and yet she's still on the recommended slate. So if she's no longer a purchaser, then why are we recommending her reappointment in the purchaser slot? So that's question number one. Because you're saying you want to hold, so I see a vacancy, hope for special recruitment. I initially presumed that was because of concerns about Iftikhar Hussain, right? Is that, tell me if I got this wrong, right?
No, I think that's absolutely right. I think we have a general paucity of purchasers who are applying to be part of it.
So to clarify then, now my understanding, of course, is Iftikhar Hussain is still midway through a term. So I guess the question I also have, so we have 2 positions here I want to ask questions about. So one is that I understand Suzanne Usage is not being viewed, at least in our discussion now, as actually truly being a purchaser. So that's raising a question to me, then why are we reappointing in the purchase slot? If you're going to do recruitment, you might as well recruit 4, right? And why are we extending this person if they don't really fit in, if the opinion of this board and the subcommittee was that they don't really fit in that category? And then the second one is, I guess, with Iftikhar Hussain, who people are perceiving also as no longer a purchaser. Now they are midway through their term, so therefore they're not up for reappointment. And then, so I guess the question I have is that, you're doing an open recruitment, I assume for that position, sort of the third purchaser position, although now it sounds like we may have two. In which case I presume that that basically this other person, when they're up for reappointment, either will be reclassified or not reappointed if there's other people in that classification to make up the three. So we're not permanently increasing the purchaser pool to 4 people, especially since at least one, if not 2 of the people already on that slot aren't really viewed as purchasers. So I want to clarify that actually we're maintaining essentially, we may have a temporary transition, but we're maintaining 3 appointments for the purchase. We're not expanding the board by another person. So we've already expanded by 1 more today with Sean Kim, but we're not continuing to expand this advisory committee.
I'm gonna turn it over to Ian in just a second, but in the meantime, I just want to ask Director Landsberg to clarify what our statute references as it relates to the advisory board, especially as it relates to a situation where a advisory member has been appointed and is not up for a redetermination, but has changed positions or changed roles. So just want to provide some clarifying statute here.
Yeah, I'm happy to start, and Michelle or CJ can add. So an appreciation to the subcommittee and the staff for the work on this. So Secretary Johnson had asked me whether it says anything about current or previous representation. So the statute does say when appointing members to the advisory committee, the board shall aim for representation, including representatives of. So I think representatives of implies current. So, the subcommittee has come up with a recommendation to the board, and certainly we can change that. So if the board decides it's not appropriate to move forward with one of the current slate, we can certainly change the motion. CJ or Vishal, anything you want to add? No. And then the board does also have the discretion to remove at any point a member of the advisory committee by a majority of the voting members of the board. So if there's a determination that it doesn't make sense to have someone serve in a category, and certainly, I think it would be appropriate, since Iftikhar has moved and now works for a hospital, we could either decide to move him to the hospital category or make some other change. And that's also within the discretion and authority of the board.
Yeah, I think he should be in the category of hospitals because that is what he's doing now. And his term is not up. And so my suggestion is that we keep him on hospitals. And when his term comes up, we have a conversation then about whether to renew or not. And that will depend on other vacancies in that category. So I'm perfectly okay with that. As for Suzanne and Mercer, I appreciate the feedback from the board on this. And her term is up. And if we chose not to reappoint her, I think the challenge for us would be to really go and try to identify 3 vacancies in the payer category, which I would encourage all of us. Well, we have a vacant one, and Suzanne, yeah. We're gonna need more payers in this mix for sure.
Yeah, likewise, I think our thinking here was we wanted balance between the hospital representatives and the purchaser or other perspectives. I certainly, if we want to keep this open and hold back on that particular reappointment, that makes sense. I would suggest that we, so that we don't end up with a meeting where we have, only one person in the purchaser category. Keep the incumbents going until we have made a final decision on who we're filling those slots with. Yeah.
The effective date for clarification is July 1st for this. Is that the effective date of what was the vote? I just want to confirm.
Yeah, the effective date would be July 1st, but the first meeting isn't until September, August.
There we go. That's helpful. Thank you.
So I think we do have some time before
Rick, then Richard.
A question of clarification. On slide 32, there are at least 3 members who have stars, Stephanie Klein, Christina Rodriguez and Katie Bassler. But then on slide 34, they're shown as being there, but not proposed for reappointment. So I'm just, can you clarify what the situation is there?
Being up, so they have stars, so they should be shown as reappointments. Yeah, there are people who are.
No, I was going to call CJ for help on that one. I don't recall in particular Katie Bassler, who was fairly recently appointed to.
So let me first correct the first thing. The next advisory committee is July 8th. Let me understand.
It's July 8th. The next advisory committee is July 8th.
Yeah, I think that it's an error, and now it's
They're not really, the stars were an error on slide.
stars an error or them not being reappointed, but this would be the slate as we would be proposing to reappoint.
We'll get some clarification on that in the background here. Go ahead, Richard.
Yeah, okay. Well, first of all, I think we do need to clarify because otherwise, technically, if Katie Bassler is up for reappointment and we don't reappoint her, she's not reappointed. So if that's the intention and she is up for reappointment, we need to be sure that's clear. So in whatever motion we make, we do that. Second of all, this is not the first time, as I think Elizabeth and I both know, where we were short on recruiting some people in a particular category. And we did do special recruitment and we were able to, I think the fact that sometimes what happens the first round, people go, oh, well, we expect most people are going to be reappointment, so they're not really searching that hard. And then when we go, hey, by the way, we actually have vacancies, right? Then people do. So to me, I'm less concerned that we're going to have a meeting with only one purchaser on there. And also, this is not a body that, you know, we're hearing the presentations from the advisory committee where we're told like, oh, it's like, 10 to 12 or something like that. It's we sort of capture each individual voices. So it's not that, so I'm less concerned. And the problem is that I probably wouldn't extend somebody for just one meeting. I mean, we're reappointing them, right? Or appointing people. So for a term. So it's sort of weird to then appoint someone to be for just one meeting so that in case we don't recruit somebody, et cetera. So, and you said we've dealt with this before. We've successfully dealt that. We don't have to reappoint someone who is not in the appropriate category. We'll just recruit for someone. There's still time to do that. And I think that, so I think if the feeling of the board and the subcommittee is that, well, actually Suzanne Usage is not really in that category, then we should not reappoint that person because that really isn't fitting there. So I do want to follow up on the physician category because the purpose of that category is to have people who are well networked, who actually are grounded in the profession. We'd have a separate group for medical groups. I appreciate the praise for Dr. Doherty, who did apply for reappointment. I have heard very little about Katina Murray, what characteristics I'm sure is a wonderful person, is bringing that makes her better connected to the physician community than Dr. Doherty, Dr. Murray. So please tell me a little more about Dr. Murray and how well connected. I'm sure she's a wonderful person with a lot of skills. I see that, what I'm a little concerned about, I'm seeing a bunch of people in the physician category who all have administrative titles, and I'd like to see people who are more grounded in practice. But maybe she is, and I just don't know because I've not reviewed her application.
Did you want to talk about her bio, Dr. Murray?
I think the staff has been looking at the issue of the stars versus the slate.
I don't have her bio right in front of me.
Okay.
I'm going to recommend board based on the fact that we have a little bit of time. That is the good news. June there's no advisory committee meeting, just to confirm that again. And we don't effectively need to take this action. It's effective July 1st. We have another board meeting in between. So I'm going to just recommend that we just get the couple points of clarification on the final slate. We can provide some additional information about the recommended new members per the board's request. And we can also, gives us a little more time in, let's put positivity out in the world for more purchasers. So we will come back for this item for June. Yes, Elizabeth,
I can
please.
just clarify one thing. So we can certainly hold this open until June. We will not have closed the purchaser recruitment. So when we come back in June, we can still carry on these conversations, answer some of these questions, make sure that we've clarified some of how this is reflected here so that there's ultimate clarity. There would still be a follow-on action at a subsequent board meeting then to likely, assuming that this plays out as I think that it will, likely appoint purchasers at some date after June. So likely at a subsequent board meeting.
Art, I think it'd be helpful as well when people have changed categories to put them in their new categories, just so everybody can appreciate where they are now.
We will reflect it as so.
Thank you.
I won't be able to vote on this, so this is sort of a parting shot. But it may be worth considering, like you did with the pharmacist, creating a category for consultants, because it really isn't about her skill or talent. It's just being in the wrong category. So, and we will proactively try to find some purchasers for you.
Thank you very much. Oh, two more. We'll go to Don, then Richard.
Yeah. I guess just for clarification, when this is presented, I get the person isn't maybe not quote unquote in the original category, but it's important to know at least what they were initially appointed for. Hopefully we're not having too many people scramble around each time, but if someone says, oh, how come we have 4 hospital people now? It's not because the board or the committee suggested 4 people in the hospitals. It's just that we had someone who moved and they were originally appointed as, and I think it's going back to, I know I've harped on this before, let's not make the advisory committee get too large. And there's a reason we have 3 people in each category. And I don't want now this to cause confusion now. Oh, well, this category is 4, so let's now expand all the other categories to 4. So.
And I just wanted to thank my colleagues, Sandra and Ian again. I think we all appreciate that this is a pretty thankless role and very kind of you to take it on. So.
I'll just echo that as someone who's sat in the role before as well.
We very much appreciate the work of the board members on this committee and this work. So again, appreciate the discussion that helps clarify. I would actually suggest to staff on appointed advisory members who in the course of their appointment change positions, that we just bring that to the board, and the board can then consider whether or not we want to move to a different category, whether we want to do more recruitment. We will have just that opportunity to share that. And then maybe we can put a asterisk if those person keeps and we move them over just for our own memory as we capture that along the way. So again, I really, really appreciate the work of the committee bringing this to the board today. And we will do the follow-on review of the slate in June. So thank you very much. Are we okay to move on? Oh, excuse me. Okay, and we'll open up public comment for this item. Thank you.
All right, we'll now take public comment on this agenda item. Please step to the podium. If you are online, please raise your hand. I do see one hand raised. Stephanie, you should be unmuted on our end. Please go ahead. It might take us just a moment. All right, Stephanie, go ahead. You should be unmuted. Stephanie, we can't hear you yet. We will come back around. I will go to the individual at the podium. Thank you.
Beth Capel for Health Access. Several of a few points on the advisory committee. We're happy that so many people participate and have such diverse perspectives. That has been helpful. I will say that not every committee member shows up for every meeting, as you would expect. So the size has been less troublesome than some might have been worried about. Health Access does have several board members that are being recommended for reappointment, and we appreciate that. And we also recognize that there's a different, we will, Iftikhar Hussain very noticeably represented the perspectives not just of hospitals, but of a particular high-cost hospital in the last committee meeting. And so we would just reflect that. And we would also note that doctors who are providing care in a hands-on way are different than administrators, and we appreciate, just as healthcare workers who are providing hands-on care are different than management. So it is a different role, and we don't envy the committee that has to make these choices and make these recommendations. So we thank them.
Thank you. Looking back virtually, seeing no hands raised, that concludes public comment on this item.
Thank you very much. We are going to move on to item 5B. This is the spending target data submission enforcement, status update and comments on the regulatory text. We'll welcome Assistant Chief Counsel Heather Hoganson.
Good morning. I'm Assistant Chief Counsel Heather Klein-Hoganson. I go by she, her pronouns, and I am here between you and lunch to talk about the spending target data submission regs. So as you may remember from April's board meeting, we went out for an informal public comment period between April 20th and May 11th. We received 2 letters, and those are in your board packets and posted online. There's 5 slides that I will go through. I'll let you read most of it because I'm sure you've all read the letters already. But so if we want to go to the first slide. The next slide. Thank you. The first comments we received were about some flexibility and stability for planning ahead. And we recognize the efforts that submitters go through to give their data to us. The proposed regulations are intended to implement the statute in a transparent, predictable, and consistent manner. And so the first 2 comments don't actually require any adjustments to the text. On the next slide, we have a comment asking OCA to set limits for our internal review and a clarification on corrections. So on these 2 slides, there's no changes that we are proposing to make. Our review process may actually take some back and forth, and so limiting ourselves to just 2 or 3 days or even 5 days may not prove adequate considering what we need to do to get the submission correct from submitters. And then as to clarifications on how corrections will be done, we feel that is sufficiently detailed in our DSG, the Data Submission Guide, and that just finished going through its rulemaking process a month ago. So we think that process is set out sufficiently. On the next slide, we had a comment asking for a longer response time from submitters. And we really believe that updates every 5 days are reasonable and necessary to make sure we get the data in. And then we also received a request to extend the consider going from may consider to must consider. And we're going to go ahead and do that for shall consider as a more appropriate legislative and regulatory word. On the next slide, we had a comment asking that OCA provide responses in writing, and we are happy to make that adjustment. And we were asked for a longer response time to make corrections. And although we did make some significant changes from the last rulemaking process, we will adjust that to 5 business days as requested. And then on the 5th and last slide of comments, we had a comment requesting for more public reporting of when submissions were not received on time. We are working on a separate public reporting schedule, but that doesn't necessarily need to be in regulation. And then we had lots of appreciation for the work that we have been doing, and we appreciate the appreciation. I will note for the board that we had no comments regarding the scope and range that the board voted upon in November 2025. And so if there are no other comments from the board, otherwise the office would plan to proceed as planned and as discussed in the April board meeting.
Thank you very much. Any questions, comments from the board? That was straightforward. Okay. We'll open it up for public comment.
We'll now take public comment on this agenda item. Please limit comments to other items to the general public comment period. Seeing no hands raised virtually, I'll go to the podium.
Beth Capel for Health Access. As board members have said, this entire enterprise rests on timely data submission. And even with the timely data submission, the process of accountability seems to us very long, months, if not years. So this is a laborious process in some respects. We have sought transparency for the THCE data submission, including public reporting at each stage of the data submission process, as well as public accountability for any penalties. We were troubled to learn months after the fact that one entity had failed to submit timely. We appreciate that they did eventually do so, but we think it's important that everyone know, including the entities, whether they're making it through the process timely, because so much of this enterprise rests on this data, so on this THCE data. So the staff masks who asked for what. I trust it's not a surprise to anyone that we asked for public transparency, and that we will continue doing so, and look forward to working with staff on that. Thank you.
Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item, and I believe takes us to lunch.
We will return at 1 p.m. Thank you very much. Welcome back. I hope you had an enjoyable lunch. Can we please call the roll?
Good afternoon. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson. Here. Richard Kronig.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell. Dr. Richard Pan.
Present.
Don Molds. 6 present, 1 absent.
Thank you. We are going to move on to item 5C, and that is the introduction to the equity adjustment and quality adjustment to spending targets. We'll welcome back Margareta, and we'll also include here the Health Equity and Quality Performance Group Manager, Maggie Heedman.
Thank you. Thank you, Secretary. Good afternoon, everyone. Again, Margareta Brandt, Assistant Deputy Director for Health System Performance at OCA, and I'm joined by Maggie Heidman, the Health Equity and Quality Performance Group Manager, to introduce the equity adjustment and quality adjustment to spending targets and OCA's proposed recommendations. So to start with a little bit of background on OCA's commitment to advancing health equity and quality for all Californians. We want to emphasize that California's healthcare system is large and complex, with a diverse mix of payers and healthcare delivery models that contribute to variation in spending, access to care, and health outcomes across the state. And despite growth in healthcare costs, higher levels of spending do not necessarily or consistently translate into better health outcomes, highlighting opportunities to improve efficiency, improve quality, reduce health disparities, and better align care delivery and payment with value. So as you all know, OCA is responsible for implementing several statutory requirements that aim to reorient the healthcare system towards greater value. And we continue to advance quality and health equity by implementing the spending targets, of course, to improve affordability, as well as through OCA's quality and equity measure set and other work streams. And across this work, we're focusing to shift towards a more value-driven healthcare system that prioritizes access to care, improved quality and equity, and affordability. And on this next slide, also wanted to start with some definitions that we'll use throughout the presentation before getting into our analysis and the results of that analysis and our proposed recommendation for the equity adjustment. So many of you all are familiar with these definitions, but just starting with health equity, in the absence of health equity is the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, geographically, or by other dimensions of inequality. And social drivers of health, also known as social determinants of health, are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, quality of life outcomes, and risk. Examples of social drivers of health are education, income, safe housing, language spoken, and literacy. And social risk refers to an individual's social and economic conditions shaped by underlying social drivers of health. And then in this analysis, we use the Social Vulnerability Index, which is a place-based social determinants of health index that is developed by the Centers for Disease Control and Prevention and the Agency for Toxic Substances and Disease Registry. And in the SVI, there are quartiles, and the SVI ranks California census tracts to a given measure of relative social vulnerability ranging from 0 to 1. And these scores have been categorized into quartiles for equal groups with higher SVI scores. That is SVI quartile 4, indicating higher social risk. And we'll talk a little bit about this in relation to the analysis we did a bit later. And then, of course, SVI quartile 4, which we'll refer to quite frequently, indicates members with highest social risk assessed through the Social Vulnerability Index. And for example, here, a member with higher social risk could be below 150% of the federal poverty level, age 65 or older, and with a disability. So to get into our details around the equity adjustment, I'll start by reviewing our statutory requirements. So in the context of the spending targets, in consultation with the board, the office shall establish equity adjustment methodologies that take into account social determinants of health and other factors related to health equity to the extent data is available and methodology has been developed and validated. And the methodology for setting a sector target for an individual healthcare entity shall be developed, taking into account the following. Allow for the setting of cost targets that encourage an individual healthcare entity to serve populations with greater healthcare risks by incorporating an equity adjustment accounting for the social determinants of health and other factors related to health equity for an entity's patient mix. So taking this, the key pieces of statute here are the equity adjustment accounts for social determinants of health and other factors related to health equity and encourages healthcare entities to serve populations with greater healthcare risks. And I'll just note on language again here that the language we'll use throughout our presentations, we will refer generally to social drivers of health, and then we'll also be using the term social risk as defined earlier. And additionally, when we refer to healthcare entity, we're referring to all of the entities that are regulated by OCA. So on this next slide, to guide our work, OCA started with what we think should be the purpose of the equity adjustment. And we want to recognize and acknowledge that all of the goals listed on this slide are lofty desired outcomes. And to emphasize that it would not need to meet all of them. An equity adjustment would not need to meet all of these goals. So we would want an equity adjustment to meet one or more of these desired outcomes, avoid potential unintended consequences of the spending targets, avoid undermining affordability by making healthcare more costly, address social drivers of health and advance health equity, encourage healthcare entities to make care more equitable for members with varying levels of social risk, and improve access, affordability, and equity of healthcare for all Californians. And on the next slide, based on statute and from our analyses, we mapped out what we think are specific things we've determined the equity adjustment is and what it is not, and we've summarized those on this slide. So starting with the is column. So an equity adjustment is an adjustment to a healthcare entity's spending growth and does not change the spending targets. For example, all healthcare entities would still have a 3.5% statewide spending target, but OCA could use an equity adjustment based on social risk to adjust the healthcare entity's spending growth downward if they had a high proportion of members with high social risk. So, for example, you could say an entity's unadjusted spending growth, it was 4.0%, but with an equity adjustment, their spending growth is adjusted downward to 3.4, meaning that they met the spending target of 3.5%. This would allow for clear upfront spending targets for all healthcare entities. Additionally, an equity adjustment is a method to identify healthcare entities serving a disproportionate share of members with high social risk using available data such as an SDOH index like we've done in our analysis. And it is an allowance for higher spending growth for healthcare entities who are serving a disproportionate share of members with high social risk. And then switching to what it is not. So it's not a source of additional funding for healthcare entities to invest in efforts to address social drivers of health. It's not a single solution, of course, to address health equity challenges in California. And it's not a requirement for healthcare entities to spend more on initiatives to address social risk and reduce health disparities. So if we can move to the next slide. So wanted to provide a bit of background and scope and talk about the process and the analyses we used and considered when evaluating a potential equity adjustment. So in terms of scope, we assessed an equity adjustment for payers and will separately assess one for physician organizations and hospitals. So when I note payer, we're referring to health plans and health insurers, and when we say providers, generally, we're referring to hospitals and physician organizations. And since 2023, we have worked with healthcare experts, consultants at Mathematica and OnPoint Health Data, analysts and researchers to review data analyses and discuss policy approaches to an equity adjustment. I'll note here as well that no other states with spending targets have an equity adjustment. So instead, we assess programs by other states and by CMS that apply social risk adjustments to payments to providers and health plans. And then in this analysis that we'll present today, we've used the Social Vulnerability Index, as I mentioned, and Healthcare Payments Data Program Data, or HPD data, to assess variation in social risk among members served by payers from 2018 to 2023. And we contracted with Mathematica to conduct this analysis. And we'll go into more details about our findings, but as a preview, payers' distribution of members by SVI quartile is very stable. And there's very little year-over-year change. And even for members with the highest social risk, that is SVI quartile 4, there's very little year-over-year change. And so with all this background and introduction in mind, I'll now pass it to Maggie Heidman to walk us through the assessment of social risk distribution among payers and our proposed recommendation.
Thank you, Margaretta. Again, my name is Maggie Heidman. I use she, her, and I am the Health Equity and Quality Performance Group Manager, and I'll walk through the assessment of social risk distribution among payers. To assess health equity, this analysis used an SDOH index focused on social risk. The analysis, 1, examined social risk of California health insurance members and how social risk is distributed across payers to identify payers who take on members with disproportionate social risk within a market, and 2, observe trends in payers' distribution of social risk over time. The healthcare payments Data Program, or HPD data, was used to assess variation in social risk among members served by California payers from 2018 to 2023. Member social risk was assessed by first applying a social vulnerability index score to each member based on address, and members were then grouped by their SVI quartile, and variation across 3 key markets was assessed: commercial, Medicare Advantage, and Medi-Cal managed care. Both distribution by SVI quartile and volume of members in SVI quartile 4, which indicates members with higher social risk, were considered. Social risk variation was analyzed at the payer level. So this analysis does not address social risk variation at the physician organization or hospital level. Next slide. So this analysis includes payers who submit data to the HPD, and the HPD includes approximately 82% of all Californians. The HPD does not have complete self-funded commercial data or data on uninsured Californians. And data completeness in the HPD is between 99.2 to 100% for required data elements that we used in this analysis, such as market category, payer, member zip code, and among others. And then over 99% of member months were successfully linked to an SVI score for all 3 market categories. This analysis does include data for Medi-Cal managed care members. However, Medi-Cal fee-for-service data is not included. And members without a Medi-Cal managed care plan code in the HPD, meaning that a member could not be assigned to a Medi-Cal managed care plan, were excluded from the analysis. And then for the Medicare Advantage, those members are included, but Medicare fee-for-service data is not included. And the pairs in this analysis differ slightly from the OCA baseline report. 2 pairs are in the OCA baseline report, but not included in this analysis because they do not have data in the HPD. And then 1 pair is included in the analysis, but is not listed in the OCA baseline report. And then on the next slide, just to provide more details, so we use the Social Vulnerability Index, or SVI, to assess members' social risk. SVI is a place-based index developed by the CDC, and this analysis uses the 2022 SVI, which equally weights 16 U.S. Census variables from the American Community Survey 2018-2022 5-year data, as well as 2020 census tracts to assign an SVI score. And the 16 variables are listed in the graphic on the right side of the slide. Again, a higher score indicates higher social risk, and our key findings are focused on members with higher social risk or the members in SVI quartile 4. For example, a member with high social risk could be below 150% of the poverty level, be age 65 and older, and have a disability. And then the SVI does have a high correlation with the California-based Healthy Places Index and uses census tracts as the geographical unit. And very few California census tracts do not have an SVI score. Census tracts with no SVI score may have had missing American Community Survey data, and therefore an SVI score could not be calculated. But approximately only 0.25% of the California population is missing an SVI score. On the next slide, I'll preview some of our key findings. So payers, again, meaning health plans or insurers, distribution of members by SVI quartile is very stable, and there's very little year-over-year change from 2018 to 2023. The commercial market has very little year-over-year variation in the percentage of members in SVI quartile 4, whereas the Medicare Advantage and Medi-Cal managed care markets have slight year-over-year variation from 2018 to 2023. And then the commercial market members have disproportionate lower social risk than members in Medicare Advantage and Medi-Cal managed care. The Medi-Cal managed care market does ensure the largest percentage of members with higher social risk, and the Medicare Advantage markets, members are almost evenly distributed across quartiles. So we'll start by looking at SVI scores by market. The lightest blue represents quartile 1, members with lower social risk, and the darkest blue represents members with highest social risk. The 2022 to 2023 SVI score distribution highlights overall patterns within market categories, and these same patterns are observed when looking at individual payers or health plans in each market category year over year. The SVI score distribution remains relatively stable in all markets from 2018 to 2023. So again, the commercial market SVI scores distribution skews towards lower social risk compared to the other markets. And Medicare Advantage, the SVI scores are fairly evenly distributed across quartiles, and then Medi-Cal managed care market enrolls members with the highest social risk. So diving into the payer level results, I'll start with the commercial market. And then to just briefly orient you to the line graph, each payer is a point on the line graph ordered from lowest to highest percentage of members in SVI quartile 4. Again, these are the members with highest social risk. And the payer names have been masked. I do want to note they're not in alphabetical order, so payer 1 may differ between the different markets. We do want to note that we received feedback in the April Advisory Committee meeting and public comment to share analysis with payer names, which we will consider doing in the future. And then for this specific line graph, we are focused on 2022 to 2023, since these are the most recent years of data that we have, and they really are representative of all 6 years of data. So the gray solid line is 2022 and the blue dashed line is 2023. Looking at the percentage of members with the highest social risk for commercial payers, there's little variation for each commercial payer from 2022 to 2023. And aside from 2 payers, the remaining 11 payers have only 11 to 20% of members with the highest social risk in 2023. And then to note, the appendix does have results for all 6 years from 2018 to 2023. Moving on to the Medicare Advantage payers. Again, there's little variation for each Medicare Advantage payer from 2022 to 2023. But there is variation between Medicare Advantage payers. The percentage of members with the highest social risk ranges from 11 to 53% in 2023. And then for the Medi-Cal managed care plans, again, there is little variation within each payer's percentage of members with the highest social risk from 2022 to 2023, but there is significant variation between Medi-Cal managed care plans. And they do have the greatest variation in social risk among payers, ranging from 12 to 68%. And one possible explanation for this is due to some Medi-Cal managed care plans being region or county specific, whereas others cover multiple service areas. Next slide. So now I'll transition us to walking through the proposed equity adjustment recommendation and rationale for payers. So our proposed recommendation is not applying an equity adjustment to payers' performance against spending targets. This means that we are recommending that we do not use an equity adjustment based on social risks to adjust a payer's spending growth downward. And just to reiterate, this recommendation applies only to payers, not to physician organizations or hospitals. Some key themes of our rationale are our analysis of social risk does not indicate that payers are seeing year-over-year variation in social risk trends. The relationship between health equity and cost is inconclusive, and the administrative burden and costs may outweigh the benefits and value of an equity adjustment. Starting with our first key theme, year-over-year social risk trends are stable. Since the spending target measures year-over-year total medical expense, or TME, per member, OCA assessed year-over-year social risk trends using the Social Vulnerability Index and Healthcare Payments Data Program data. The analysis we presented showed that while social risk distribution between payers varies between payers, there's little year-over-year change from 2018 to 2023. In markets and payers, social risk distribution remains very stable from year to year. The stability of payer social risk mix suggests that changes in members' social risk profiles are not driving annual per capita spending increases, and therefore an equity adjustment may not be needed. Given the stability of member social risk, an equity adjustment based on member social risk may have minimal impact on the payer's performance against spending targets. Okay. While there is social risk data available through the SVI and other sources, the relationship between social risk and cost is inconclusive. A cohort study of members with complex medical comorbidity found that social risks were associated with higher odds of inpatient admissions, emergency department visits, and mental health visits during a one-year period. This could indicate that members with social risks have greater healthcare spending. Conversely, lower healthcare spending could be attributed to certain populations skipping needed care for chronic conditions due to cost or access challenges. In 2025, 70% of Californians with low incomes under 200% of the federal poverty level reported skipping or delaying care due to cost. Standardized social risk data collection at the clinical level remains limited, and gaps are driven by insufficient training and support for providers to ensure data privacy, ethical use of data to avoid unintended consequences, as well as building trust with patients when collecting social risk information. Research continues to emphasize the need to better understand the interaction between social risk and costs. These points emphasize that the relationship between social risk and cost is inconclusive, and in particular, there are gaps in data collection and research on the interconnected relationship between equity, quality, and cost. In addition, OCA's spending targets are centered on median household income and advance health equity by focusing on a metric that directly reflects what consumers can afford. And the impact of incentivizing additional spending through an equity adjustment, particularly for members with the highest social risk, is unknown. Furthermore, OCA cannot guarantee that the additional spending growth allowed through an equity adjustment would address social risk. On the next slide, we show that we ran our own unweighted Pearson's correlation analysis to see if we saw a relationship between the percentage of members in SVI quartile 4 and total medical expense per member per year in 2023. OCA's payer level or health plan level analysis shows a negative correlation between the percentage of members in SVI quartile 4 and total medical expense per member per year in commercial and Medi-Cal managed care markets, while in the Medicare Advantage market, it shows a positive correlation. Although I will note that these should be interpreted with caution due to the small number of observations. On the next slide, the administrative burden and costs of implementing an equity adjustment for both payers and OCA may outweigh the benefits and value. To implement an equity adjustment, payers may be required to submit additional data to assess the distribution of their members' social risk. For example, OCA may need member address data from payers. In addition, payers would be required to engage with OCA on additional data validation. An equity adjustment would be resource intensive to ensure data completeness and accuracy and conduct detailed analysis. And then the benefits to affordability are unclear as the impact of incentivizing additional spending for members with the highest social risk is unknown. And then lastly, the value is not compelling since social risk trends are stable and the relationship between health equity and cost is inconclusive. On the next slide, in the absence of meaningful changes in social risk profiles and because the relationship between social risk and cost is inconclusive, implementing an equity adjustment for all payers may not be necessary at this time. Continued monitoring may be more appropriate. OCA would still assess if a payer met the spending target using unadjusted data, but could consider evaluating changes in social risk when determining if a payer proceeds in the enforcement process. The enforcement process would give entities an opportunity to explain with supporting evidence how increases in members with the highest social risk and/or a disproportionate number of members with the highest social risk impacted excess spending growth. And then OCA cannot validate the relationship between social risk and excess spending growth based on data we already collect. We may need to ask for more data during the enforcement process, since changes in social risk may not appear in claims or non-claims data. And then here to provide a high-level summary of feedback received during the April Advisory Committee presentation. Several advisory committee members expressed support for the recommendation. Some AC members discussed current social risk data limitations, including concerns about unintended consequences of demographic data collection, SDOH index biases, and they need to understand how SDOH, illness severity, and cost interact. Some AC members proposed additional analyses. One AC member suggested conducting a pilot with one region to track changes in SDOH over time. And then some AC members recommended separating covered California from the broader commercial market to better understand how population differences and variation in social risk. Some AC members cautioned against moving forward before completing analyses of social risk for physician organizations and hospitals. One AC member noted that stability in SVI quartiles does not mean community health needs are stable, and that a lack of change in data should not be interpreted as lack of need for support. And then during public comment, one commenter supported the recommendation and encouraged unmasking payer names at future board meetings, suggested including payer enrollment data, and proposed that assessing performance by market could be the equity adjustment. And then here again is a summary of the proposed equity adjustment recommendation for payers. Our proposed recommendation is not applying an equity adjustment to payers' performance against spending targets. Our proposed approach is to evaluate changes in social risk for payers through the enforcement considerations process. And then again, just while presenting a proposed recommendation against the payer level equity adjustment, we do really want to emphasize our commitment to supporting efforts to improve health equity, and that this recommendation, we feel, aligns with OCA's goal to shift towards a high value system that curbs spending while promoting high quality and equitable care for all. And then just to review our next steps, over time, OCA will continue to assess an equity adjustment suitability for improving health equity. We will monitor and assess new equity adjustment methodologies used by other programs and explore opportunities or emphasize the need for additional research into the interconnected relationship between equity, quality, and cost. And our next steps are to assess whether and how to develop an equity adjustment for physician organizations and hospitals. Based on our analysis of SVI and HPD data for payers, we hypothesize that an analysis for hospitals and physician organizations will show similar results, that there's little year-over-year variation in the distribution of members by SVI quartile for hospitals and physician organizations. However, we'll also conduct more literature research and engage expert consultants about an equity adjustment for physician organizations and hospitals. And I will now pass it to the chair to facilitate discussion with the board.
Thank you very much, and appreciate the thorough review also of what advisory committee members had to say about this potential recommendation as well. I think Richard, yeah.
First of all, thank you for the presentation. For full disclosure, I was the one who put that language into the legislation. So just to let you know. And the reason why is because I think we need to recognize that taking care of, well, oftentimes we talk about how your zip code's your life expectancy. I know the some of our philanthropic partners have emphasized that, the California Endowment amongst them. And So what happens is someone who tries to provide care to someone who has fewer community supports, it's more difficult, and we can argue potentially more costly. You have someone who doesn't speak English, and you need to have an interpreter. In fact, we know too often, even though there are technically requirements to provide those interpreters, that you end up having a family member and you get suboptimal care. We also know that, for example, our Medi-Cal patients, who, of course, at the lower end of the socioeconomic scale by definition, that their own ratings of the plans that are Medi-Cal are much lower than the plans than commercial plans using the same standardized instruments. So equity work is hard, and the challenge is that, and even in crafting this legislation, recognizing that we don't really have really good tools for this, right? So I appreciate you tried to take this one index and try to look at this. And I'm not surprised, by the way, that you're finding amongst the plans, you see a fairly wide variation between the plans, but basically where the plan is in the same place, right? That stays constant per plan, right? Because they've probably, well, there's a saying in quality improvement, right? Every system produces the results it produces, right? And so what happens is that probably every organization and plan has carved out their niche, right? Their market area, whatever else. Yes, they do compete somewhat with each other, but you're a Medi-Cal plan, you do certain things, and you live by the Medi-Cal system, you're Medicare, and so forth. So I'm not surprised, and they serve certain geographies that we don't see a large variation from over time of the same plan. But you can see there's a significant difference between one end of the plan and the other in terms of the average social risk. Now, you can say, well, they're not moving a lot between there, but maybe that's the problem. And in fact, one of the challenges, and I know we discussed, and I appreciate the staff talking to me this before the meeting, I think one of the challenges that we only do on the enforcement end, there's no incentive to say, hey, maybe I'll take on a population that can be more challenging. I think, in fact, I think the fact that all the plan is in where they are sort of speaks to probably the lack of competition or desire to change your profile. Right? That's why everyone stays in the same place. And actually that's disturbing to me, because we're not going to make improvements in equity if everyone's like, you know what, it's not worth investing in. And I think we have an opportunity to think about changing that dynamic. We're not going to be, we're not going to change the whole thing by ourselves. We don't have a sole measure. There's probably a lot of work to be done to figure out what kind of measures we might look at. I mean, some of the things that definitely we know cost more is, for example, interpreter services. But you might want to think about that. A lot of plans and groups and so forth know that's going to cost them more, and either avoid those populations. Sometimes in LA, I've heard from providers who speak in language that oftentimes they have harder time getting contracts because people don't want to take on those populations. That's a problem. And so, I certainly understand that we probably need some more work on some of the tools, and maybe it's not quite ripe yet, but a little aspirational in putting it in there. I would say is that I'd like to see, instead of just a blanket recommendation that we're not going to apply it, is that we put a time stop on that and say, well, we're going to revisit this next year or the year after, and we're also going to encourage people to do some work on this area to see whether we can develop some usable tools. I appreciate the staff trying to take a look at existing stuff, and you're right, there isn't a whole lot of good stuff out there right now, because frankly, this is an underinvested area. But hopefully we can stimulate some greater interest or investment and get some people thinking about it, some more people thinking about it, and see whether we can at least make some incremental changes. So it's probably not going to be a grand equity adjuster that covers all of social terms of health, but maybe we can chip away at some things like what happens, are people basically doing, do we have equal access for people who are, who don't speak English as a primary language, right? Do we have, some other areas as well? Chronic disease, we talked about importance of chronic disease and primary care, right? Well, if the primary care, so if you have diabetes and you live in an area with less support, then you have diabetes and you're much better off. There might be a difference in what it takes to take care of that person to achieve the same level of quality of care. And really, ultimately, part of the equation, what we're not talking as much about is, are all the things, we see this variation, are they all getting the same quality of care? Because that's the real problem. If there's a difference in the quality of care, then we need to create some incentives to bring up, and that's equity, right? that's why we have an equity adjuster. So I guess I would say is that I'm hoping for recommendations that's a little more forward thinking. I get the staff struggle with, because we have to operationalize all of this in terms of like, are we ready right now to put an equity adjuster? Probably not, but we could work toward getting there, and ideally, hopefully sooner than later. And let's send the signal that we'd like people to think about it and work on it sooner.
Thank you, Rick.
Yeah, thank you. Thanks for the presentation. I would support the recommendation from one of your advisory committee members about identifying the payers. I think, in the interest of transparency, that would be useful information to have, unless there's some big concern about data quality that would lead in the other direction. I also, you focused a lot on the lack of year-to-year variation in SVI as one of the rationales for not proposing an adjuster. I think the more important question is, or as important question, is not year-to-year variation in SVI, but what is the relationship between SVI and year-to-year growth in spending? The sort of, maybe a oversimplified example would be, not on SVI, but easier to think about on age. If you had one health plan, one payer that was mostly serving 85-year-olds and another payer that was mostly serving 30-year-olds, even if the distribution didn't change from year to year, the payer with the 85-year-olds would be expected to have higher health spending growth from one year to the next, because us old people are closer to death and our spending goes up more from year to year than is true for a 30-year-old. And I don't think we have similar evidence around SVI. I don't think we know, to your kind of supporting your position of, well, we're not quite ready to do anything yet. We don't know that spending increases more for people who are more vulnerable. And even if it doesn't now, maybe it should. And so there's sort of the question both of what does the empirical data show and what's a kind of normative position. But all to say that as we go forward, focusing not only or even mostly on whether there are changes from year to year in the distribution of SVI, but rather the relationship between SVI and growth of spending is something that I think we ought to be paying attention to. And then my last comment on this is that there is still kind of nascent, but some work on developing quality indicators, and we did talk about this 6 months or a year ago, I forget when, that measure the outcomes separately by at least race and ethnicity. And I think we ought to be paying attention to that as well as we're looking at kind of equity adjustments and trying to encourage and reward the payers and the provider groups that are reducing disparities in measured outcomes within the patients that they're taking care of.
Rick, I wanted to make sure you're tracking. We did say the relationships inconclusive between social risk and cost or spending.
Yes, although the analysis that was presented was the relationship between social risk and cost. I think when we have the data available, what we should be more focused on is the relationship between social risk and change in cost, which I imagine will also show nothing, that we're not going to see anything. But, that's what we're focused on, right? It's sort of, should there be an adjustment in performance, or actually, I didn't raise this in targets. I know, Margareta, you presented the slide that said the adjustment is the adjustment to performance, not to targets. It's not clear to me why that is.
That's correct. It'd be it's similar to like the age and sex adjustment that OCA is using. We wouldn't adjust the target, but we would adjust the spending data.
So then if we're adjusting spending, then the question is whether the change in spending should be adjusted for plans or providers that are serving more vulnerable people. Whether there is any either empirical basis or just a normative basis to say, if you're serving a lot, disproportionate numbers of vulnerable people, we allow your performance we allow spending to grow by more. And again, I don't think we're ready to say, I'm sure we're not ready. I'm not ready to say that today, but continuing to try to figure this out makes sense.
Ian?
I gotta say, this is a very complicated issue, but the broad recommendation makes a lot of sense to me, given all the lack of correlation that you spelled out, and also just my general attitude that we should minimize the number of adjustments that we make to the target. I do want to say on slide 69, I'm going to do exactly what you cautioned us not to do and read too much into those correlations. The fact that there is a negative correlation for commercial SVI quartile and price or spending rather doesn't surprise me. Cost barriers to care would lead to lower spending, but the fact that you had a similar pattern for Medi-Cal was it was interesting to me, and suggested that in those communities that have lower SVI, there are practice patterns, or maybe practice patterns, that are informed by treating other patients who aren't in Medi-Cal. And I would, really not want to see a bunch of unnecessary care delivered as a result of perverse incentives. I think my question, having said the broad recommendation here makes sense, is if we were to go forward with this and not adjust the payer metrics, what would it mean? What would that mean if, for whatever reason, we chose to do something different with certain sets of providers who those payers are paying?
Yeah, maybe to make sure I'm interpreting your question, do you mean if we did not implement an equity adjustment for payers, but rather looked at an equity adjustment for provider organizations, or sorry?
Yeah, I inferred that this was specific to payers, and I think so. For instance, translation expenses or what have you, or payers certainly have that. But the discussion was around providers. If I'm not arguing for it, but if we were to consider that for providers, what would the dynamics be if we were not doing it for payers?
I think so. I guess I think we would want to do some type, if we have the data available, we would want to do a similar analysis for the membership of physician organizations, and also look at hospitals to conduct a similar analysis of their potentially attributed patient population or their patient population, and then look at the relationship, as we have done here, with spending, and could also incorporate Rick's suggestion to look at spending change over time. I think the difference would, and welcome Vishal and Maggie to weigh in here, but I think the difference potentially would be that it would allow for greater spending growth for those organizations where we implemented an equity adjustment. The challenge, I think, with the implement of the equity adjustment is that we can't exactly direct where that extra spending growth goes. So, we could note that we have made an equity adjustment and that we want this spending growth to go towards, addressing social risk or creating more support services to address social risk. But that would be, I think, quite challenging for us to track how that extra spending growth is used and spent.
Elizabeth.
Yeah, well, first of all, I appreciate the intent of this being in our language, and I really do appreciate the work that was done to try to flesh this out. I agree with the recommendation in terms of where we are now. I do think, by the way, that the suggestion from the advisory committee around transparency here is valuable, and so I'm not sure why we wouldn't do that. If the team has a concern, I'd love to know what that might be. I guess the question I have is, rather than thinking about equity adjustments to targets, wouldn't it make more sense for us to think about if an entity comes in or a payer comes in and for some reason is on a PIP, the onus on them to talk to us about what data they are using and how they are using those dollars to meet folks that are in these socially vulnerable conditions. You could imagine a hospital sitting in a neighborhood that is in SVI 4 and spending more money based on who they're serving and their geography and the like. And so I'm just wondering, rather than thinking about it as an equity adjustment, might we not ask those entities who come in who maybe exceed the target to have them explain how who they serve is driving that and how those dollars are flowing? It's just a different way at trying to get at this issue.
Yeah, as part of a performance improvement plan, the entity is required to identify causes for spending growth. And if it is, social risks attached with the population, they could propose strategies or investments in those areas, and that could be part of their PIP.
Or in them explaining why their spend is what it is, they may actually already have good data about where those dollars are being spent, and so we could learn something from that.
Are you thinking about earlier, before a PIP happens? Yeah, because of the
put them on a PIP. Yeah. They're going to come and explain why. They're going to explain why their expenditures are what they are. They may have good data that would be valuable to us to understand how social vulnerability is playing into that spending.
Yeah. They could do it in that channel, as well as when they're notified that they've exceeded the target, which is our recommendation that it be considered on the back end as part of enforcement considerations, so that because the data we're collecting won't have that level of granularity. So if they truly are making a lot of investments, then they could provide us the supporting data information about those investments.
Yeah, my point is we might learn quite a bit about how those dollars are actually spent to address social vulnerability. And so I'm doing this in part to not just address the PIP, but what we're learning from those institutions that are doing those kinds of investments.
To learn more about kind of which ones are working the best. And okay.
All right, we're going to go to Ian and then Don. Elizabeth, then Don.
Thank you. I think I'm largely in agreement with Sandra. I especially with the health plans, I think we want to hold them accountable for addressing these issues rather than give them more money. And I think that there's a risk of sort of adjusting away accountability. So I think I strongly prefer at least an initial approach being one of transparency and continued accountability, for what it's worth.
I'm in the same place, and I'll add that I think a couple of things. One is that because an insurer say has a high number of socially vulnerable folks, doesn't necessarily mean they're making investments to do anything about it. And And that's, and if we just count and don't look at what they're doing to fix, to address the challenges, that's a problem. So I think it would be really healthy to signal, just in the interest of transparency of the rules of the game, that if you are making investments to improve the health of vulnerable people, that is going to count when you're being evaluated. That seems like the right place to be. I took you to be sort of arguing for that framework, which just makes a ton of sense to me.
So I think that appreciate that basically accountability is important and outcomes, right? And I think what we're trying to do is, again, we're trying to move the needle in equity. And unfortunately, probably with people who are more socially vulnerable, that sometimes the easiest way to deal with what's going on there is just deprive them of quality services, right? Don't contract with the end language providers. Don't save money. Don't do certain things, because they're least likely to complain, least likely to have the fewer resources to demand change. So I think that, I think the thing that I just want to be cautious about, and you're right, it's not just about making a gesture and saying, here's some more money. It is about not being a barrier to someone investing to address equity, right? So this is a tool and opportunity to do that. We're probably not quite ready today or now, right? We don't have the tools, but we should be working toward developing those tools. And I think that we do need to, I think, as Don said, send a signal to people, because it's not just about at the back end, oh, once we punish you, we'll take it, we'll factor that in. We do need to send a more forward sending signal, to me, in my view, to the plans, whether it's, in some way, not necessarily by putting an adjuster right now, but basically signaling to them that this is something that we're going to be expecting and looking for. And that's also why I said that we may not be ready right now. I also would like to have a less open-ended recommendation that just says we're not going to do this, and said that, well, we'll revisit this in a few years, and we would encourage in the process. Now we're not just putting it off. We would encourage researchers, other people, to help us start figuring this very complicated question out, right? I mean, we do need people to work on how to figure this out. So I appreciate there's some emerging stuff, et cetera, but we could use some help in trying to figure out how we get there. And the fact that it's already in the statute is an opportunity so you don't have to go back to the legislature to get it. You can, if we can figure it out, then we can go ahead and move forward in it once we have the tools and the data available.
Thank you very much, Dr. Pan. I just really want to appreciate the board, the conversation from the board. And I remember having these conversations with you when we were working on the language, and your, desire to make sure that the spending targets don't unnecessarily mean that we can't have investment that promote equity and quality. And so I think it's, all the points are helpful to say, as Don did, that investment, just because they're spending more money doesn't mean they're spending it on the right way. And we're very aware of the equity concerns that you're raising around language access and higher needs populations not necessarily getting the care that you need. And so we don't think that the equity adjustment is the way to get it, and very much hear you and think it's important for us to continue to think about, is there something we can do during the PIP process? Is there something we can do at the data process? The data analysis point with entities that exceed the cost targets, to ask them what they're doing to promote equity. And so certainly take that very seriously. And so appreciate the extra time you spent with the team, and very open to additional ideas, and we will continue to think it through as well.
Just want to kind of maybe echo what other subject matter expertise and support we can bring to this. The vulnerability index is vulnerable. If you clicked on the source document for the vulnerability index, you received a disclosure from the federal government that basically said they had to do this through litigation, had to continue to post. So they took it down. So I underscore that point, because I think the conversation that the board is having here around how we are addressing a cost associated with supporting people who are vulnerable, and our intent and desire to address that as part of our overall affordability and ensure. I also appreciated very much. I think this is slide, let me get my numbers right here, slide 54, which said, what we are and aren't trying to accomplish in the adjustment. But just again, I just think for a number of reasons, getting some additional subject matter expertise and support on the concepts of how the relationships here would be helpful. And I also support just that we are saying in this moment. So being able to revisit this conversation, I know this is an informational item, not for us to necessarily vote on today, but that we are absolutely revisiting and identifying who those other subject matter experts that can support and continue this conversation live. I also appreciate the advisory committee's kind of flags on data. We are thinking a lot about data and data security and privacy. And so appreciate that we're going to consider all of those components too as we continue to look at how we're overall archingly driving health equity in the state. So just wanted to appreciate that. With that, we're going to go to quality now, correct? Or do we want to go to public comments? Yeah, please.
Kind of pile on and state the obvious. To Dr. Pan's point, and I think everybody agrees, to not let this go. We're not ready to do this, but the tragedy of America and in part American healthcare is the 10-year disparity in life expectancy between people with assets and people without. And we're not going to fix that here, but it would also be a big mistake to let it go. Yeah.
Appreciate that. Did you want to take public comment on this first component or go to quality and then take public comment? Public comment? So, okay. We'll go ahead and take public comment on the equity component of this agenda item.
We'll now take public comment on this item. Looking virtually, I have a hand raised. We'll start there. Kimberly, you should be unmuted on our end. Go ahead.
Hi, can you hear me?
We can. Go
Hi
ahead.
there, this is Kimberly Carey with Midpoint Management. We're the administrative management entity for about 2 million managed care recipients statewide. And one thing I think that we would all benefit from in this type of presentation is what was going on in the marketplace during that time that we're reporting the costs on. If you really think about it, when we look at 22 and 23, those were significant coming out of COVID periods where we had a marked drop in our commercial membership and a significant increase in the Medi-Cal membership due to the unemployment rates for COVID. So I think if we would identify certain market factors that would have an impact on cost, quality, and also the severity index, I think it's really important that we somehow put a pin on it to describe it, mainly because what I was thinking about, especially in the Medi-Cal marketplace, is that during 2023 is when the final adult UIS population came in. And it took them some time to get adjusted to receive services. So there was a lot of volatility in the market that changed things substantially. There was also a lot of Medi-Cal market membership increase. And whenever you have substantial increases, there's always a lag between the increase in membership and the receiving of care. So I just wanted to suggest that we add a slide like that talks about what was happening during the period of time we were reporting on, especially when it comes to financials and severity of illness and changes in the marketplace. Thank you.
Thank you. To the podium.
Beth Capel, Health Access California, and to the last comment, that's why we appreciated the appendix with the data from 2018 to 2023, so we could see that the results were functionally the same as they were from 2022 to 2023. We very much seek transparency. It is difficult for us to provide thoughtful comments when we don't know the name of the payer or their enrollment or their role in the market. When we look at the commercial market, we have two payers that are different than the others in terms of their range. And I don't know if those are less than a sliver of the market or the vast majority of the market. I don't know if that's Kaiser and Blue Shield or two small payers that are primarily in the Medi-Cal managed care market and the covered California market. Similarly, when we look at the Medicare Advantage slides, you have a big range, 10% to 50%. So despite the relatively even distribution by quartile. So we can't tell what's up, and that's true as well for the Medi-Cal market where there's an even bigger range. I agree with the board that thinking about the purpose of the equity adjustment, we have the question about whether increased health spending actually improves health outcomes, which we know it does not always, but it could. We would also ask, Madam Secretary, so much of the social determinants of health are actually on the human services side of the equation. And when we look at other countries, they invest there. When we're talking about things like food insecurity, housing instability, and adequate wages, the answer is should not be on the health side of the equation. And so we have to ask whether another dollar spent on health improves outcomes as much as another dollar spent on food or housing or wages. And I think that's the bigger question for us to ask. We are also reminded that we hope we will be seeing quality data stratified. And I had to write down the acronym so I could remember it, RELD SOGI, race, ethnicity, language, disability, which every payer knows, and sexual orientation and gender identity, which we're still in the process of collecting data on. But certainly for disability and age, most payers know it. The one advantage both Covered California and Medi-Cal have is they know income, which most payers do not, although some payers could probably give us a pretty good range. So the final point I'll make is that one of the things that at least some of us didn't contemplate when we were working on the legislation is that we would measure everything by market segment. And the segmentation into Medicare Advantage, Medi-Cal managed care, and commercial in part segregates by age and income.
3 minutes.
And so that is in some senses an equity adjustment in and of itself. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record, we have about estimated 90 virtual attendees. That concludes public comment on this item.
We'll continue on this item on the quality component. Thank you.
Thank you. So appreciate, again, the thoughtful feedback and discussion, and look forward to continuing to work on progressing our work related to the equity adjustment and equity related analyses. So now I'll shift us to present on the background and proposed quality adjustment recommendation. So if we could go to the next slide, just as we usually do, starting with statute. So the based on statute, the methodology for the spending target shall allow the board to adjust targets downward when warranted for healthcare entities that deliver high cost care that is not commensurate with improvement in quality. It should also allow the board to adjust targets upward when warranted for healthcare entities that deliver low cost, high quality care. Statute notes that data sources on cost and quality performance of healthcare entities may include cost and quality performance data reported or sourced from recognized quality improvement and transparency initiatives, supplemental data such as financial data on healthcare entities submitted to state agencies, data on cost, payments, quality from the Healthcare Payments Data Program, HPD, and other relevant federal, state, or local data. And also to add context here, similar to the equity adjustment, other states with spending targets do not have a similar quality adjustment. However, some states do have mechanisms for taking quality into account. For example, Massachusetts reports on quality of care in their annual report, in addition to reporting on total medical expense, which is similar to how OCA will approach its future annual reports. So if we can move to the next slide, I'll start here with our proposed overall recommendation. So our proposed recommendation here is to wait to apply a quality adjustment to the spending targets. We would like to note that we have slightly revised this recommendation as we move through the development process, and it's a revised recommendation than what we presented to the advisory committee. So our proposed recommendation applies both to entities that deliver high-cost care not commensurate with improvements in quality and entities that deliver low-cost, high-quality care. And this recommendation would apply to all healthcare entities regulated by OCA, not just payers, as we focus on for the equity adjustment discussion. So OCA will continue to monitor healthcare costs and quality data, and we recommend that we reassess quality adjustment factors in about 2 years. And the key points of our recommendation are that research data and analyses demonstrate that there is minimal link or no link between healthcare cost and quality. We also recommend waiting because until OCA has several years of experience analyzing both total medical expense data and quality performance data, and want to note that sibling departments, especially such as the Department of Managed Healthcare, are still implementing their quality performance programs, which OCA will be relying on in our quality and equity measure set. So in the next few slides, we'll go into more detail. So the following slides summarize some key findings from research, data, and analyses on the relationship between cost and quality. A few key points here. So one, a systematic review of published literature for studies that examined the association between quality or cost or spending measures showed evidence that the direction of association between healthcare cost and quality is inconsistent. Most studies have found that the association between cost and quality is small to moderate, regardless of whether the direction is positive or negative. Other research also shows that there's minimal or no link between cost and quality for hospitals. For hospitals, some research has found that cost might be associated with better outcomes in competitive markets, but not in concentrated markets, potentially implying that prices might reflect market power, not superior quality. Also, as you all might remember, in the August 2024 board meeting, Christopher Whaley presented findings from his examination of hospital prices, and two of those key findings were that hospital price increases don't lead to quality improvements, and variation in California hospital prices are not linked to CMS quality stars. So, and we'll just repeat two of those slides here. So here on slide 80, this is the slide from Christopher Whaley's presentation showing results from a national study that hospital price increases did not lead to quality improvements. And the visualization shows the change in quality associated with a 2% increase in discharge price. And on the left-hand side are quality measures, and the colored bar shows in blue quality improvement and in orange quality decreases. And just overall, this shows that increasing prices does not consistently improve quality. And the next slide is another repeat from that board slide, so showing that California hospital prices are not linked to CMS quality star ratings. And instead, we see a random distribution of cost within each quality grouping, as Whaley noted in August 2024. So on the next slide, here we wanted to provide a bit of information about the relationship between quality and cost for payers and physician organizations. Again, here we don't necessarily see that higher costs lead to higher quality care. Analysis by the Integrated Healthcare Association's Cost and Quality Atlas showed variation in payer cost and quality, particularly by product type, HMO versus PPO, and financial risk sharing. The Atlas analysis shows that better quality and lower cost are associated with HMOs and ACOs compared to PPOs. And this analysis suggests that potentially achieving higher quality with lower cost is feasible. And again, from the Office of the Patient Advocate, Health Care Quality Report Cards for physician organizations, you see a wide variation in physician organizations that deliver high quality, lower cost care, while others deliver high quality and higher cost care. And if we go to the next slide, so we recommend that OCA consider a quality adjustment after several years of experience analyzing the OCA total medical expense and quality performance data. We think at this time it would be premature to use the OCA TME data and quality and equity measure set data to evaluate when a quality adjustment is warranted. The OCA TME data is a bit early in its collection, so we're moving into our third year this fall of data collection. And as we've discussed today, we're still developing the enforcement considerations process and recommendations for the performance improvement plan process and the penalty structure for exceeding the spending target. And then also want to note that we are still moving forward with collecting data for the OCA quality and equity measure set from our fellow sibling state departments and across HCI. So we'll publish our first report on the OCA quality and equity measure set in 2027. So it'll take us time to analyze the data and potentially develop an approach for a quality adjustment. Finally, one more piece of context and rationale here is that we would like to align with our sibling department programs, as I mentioned, in how they are assessing and benchmarking quality performance. So although some sibling departments have been doing quality performance assessments for many years, including our own HCI Office of the Patient Advocate, other sibling departments are still implementing their quality performance programs. For example, the DMHC plans to release its first report on the health equity and quality measure set data in 2026, so should be coming out sometime later this year. And the DMHC has until January 1st, 2027 to promulgate regulations codifying the measures and the benchmarks. Also, HCI just released its first hospital equity measures reports in April 2026. And under current statute, HCI's enforcement authority is limited to fining hospitals that fail to submit a report by the due date. And the Health Equity Measures Advisory Committee, that's the advisory committee that advises on this measure set, is required to make recommendations to HCI to revise the measure, the hospital equity measure reports, and potentially associated statute by September of 2027. So we are HCI is continuing to analyze the data in the hospital equity measures reports and to identify and implement data collection improvements. So on this next slide, again here, wanted to provide a recap of the advisory committee feedback on the quality adjustment. I'll note that this has slightly revised since we've refined our recommendation over time. At the time, our proposed recommendation was to not apply a quality adjustment to the spending targets. Several AC members expressed support for that prior recommendation. Some members requested that we recognize entities that are high quality entities. Another member recommended that quality performance be considered in the enforcement process, and during public comment, an individual supported the recommendation and noted that statute language states that a quality adjustment may be done. So to summarize, this is our proposed recommendation again. So our recommendation is to wait to apply a quality adjustment to the spending targets. It applies both to the entities, both types of entities mentioned specifically in statute, those that deliver high cost care, not commensurate with improvements in quality, and entities that deliver low cost, high quality care. For next steps, we'll continue to monitor cost and quality data and reassess quality adjustment factors in about 2 years. We will continue to monitor how sibling departments are assessing and benchmarking quality performance. And then also wanted to note, we will provide an update to the advisory committee on this recommendation. And again, I'll pass it back to the chair to facilitate discussion.
Thank you very much. Board members.
Elizabeth?
I would just concur. And I think we shared our analysis that we did using claims, tick data, quality and safety data. And like, there is no meaningful correlation between cost and quality. We're happy to sort of share that to the extent that it's helpful, but it is completely aligned. I guess my request, and again, this is a parting shot, but I think there should be attention given to low quality driving up cost. In the example of John Muir Hospital that I referenced earlier today, their low quality care dramatically drove up cost. I think there has been far less examination of that. I am happy to participate in any way that's possible, but I also don't believe that there is any agency looking at that. I don't believe there is a regulatory infrastructure to go after hospital quality failings, and I believe that is probably a contributor to cost.
I've been in support of your recommendation.
Yeah, I too support the recommendation. I think hopefully we can apply some of the same things we do the recommendation to the equity adjuster about time frame, et cetera. So, I mean, we're probably not quite as far along in terms of data and stuff on the equity. So, but still, I think the idea is that clearly there's an intent to keep moving forward on this and looking at it. Yeah, I think that this idea of this correlation or lack of correlation between quality and cost, it's not going to be I mean, usually when you try to do these correlations, the underlying statistics is that there's a sort of a linear link between the two, and that's clearly not the case, right? You can have low quality that drives up costs actually because the low quality results in actually generating more demand or more utilization, right? Because the lower quality leads to poor outcomes. There's probably a point where, yes, if the spending was way too low that you can't achieve quality, but that it's not going to show up farther down where basically there's going to be these connections. So it's not going to be a straight linear correlation there. And so I think that I just want to be a little cautious about drawing that line. One could argue that we may be spending so much on healthcare that quote bottom inflection point may be below every institution. We don't know, but I think that do want to recognize that. But I think I appreciate the point that yes, poor quality can actually result in higher costs, certainly to the system, potentially to the institution itself, just because it produces those poor outcomes result in more need for more healthcare actually.
Yeah, I'm encouraged by how much activity there's going on at this point in terms of other entities working on quality measures and data sets. So I think that's noteworthy, and staying in those conversations and learning from what they are learning in data collection and what they're finding in correlations would be valuable to us. And I support the recommendation that you have on the table. Thank you for the work.
Maybe I'll just add, I hope that a similar amount of activity might take place around equity too.
Noted, and also appreciate the recommendation. Okay, I think we are going to turn it over for public comment on the quality adjustment component of this item.
We'll now take public comment on this item. Seeing no hands raised online, we'll go to the podium.
Hello, everyone. My name is Julia Weisner, and I'm here to speak on behalf of Kaiser Permanente as an industry leader in providing high-quality, value-based care to its members. While research on the relationship between cost and quality is mixed and nuanced, there is substantial evidence that certain investments in spending improve outcomes, such as behavioral health integration, patient safety infrastructure, health information technology, maternal health, and quality improvement initiatives. A spending target that does not account for quality or patient outcomes risks creating unintended and perverse incentives. Entities may feel pressure to reduce utilization, narrow access, delay investments, or limit services in ways that lower short-term spending but adversely affect patient care, safety, and outcomes. Incorporating a quality adjustment into the spending target framework or as a factor in the enforcement considerations process would incentivize organizations to deliver efficient, high-quality care rather than simply reduce expenditures, and would also better align incentives with the broader goals of California's healthcare system by encouraging organizations to pursue efficiencies that improve care delivery rather than through reduced access or underinvestment. We encourage OCA to consider a methodology that incorporates meaningful quality and safety metrics alongside spending growth targets, including measures related to access to preventative and primary care, patient safety and outcomes, behavioral health integration, maternal health outcomes, health equity and disparities reduction, and avoidable hospitalizations and readmissions. Kaiser Permanente believes California has an opportunity to lead nationally by demonstrating that affordability initiatives can promote both fiscal sustainability and high-quality patient care. We would be happy to continue to work with OCA and the board on evaluating quality measurement opportunities. Thank you for your time and attention.
Thank you. Looking virtually, seeing no hands raised, we'll go back to the podium.
Members of the board, staff, Steve McDougall with CFTA, Union of Educators and Classified Professionals. CFTA agrees in waiting to apply quality adjustment to spending targets. Makes sense, and it certainly should be included. When, you have one of the highest cost hospitals in the nation, let alone California, one of the 7 here, who can't crack a CMS rating above a 3, but yet has a substantial reserve at the same time. I believe over $1 billion. So let's wait and see if they can get it together and make the adjustments when the time comes. Thank you for listening.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Beth Capel with Health Access California. Appreciate our friends from Monterey grounding the conversation. We very much support and have supported and participated in much of the work to develop quality and equity measures across multiple state agencies, and look forward to the benefits of those work, and also look forward to incorporating CDPH's work on hospital-acquired infections in order to promote safety. And again, as we saw with the high-cost hospitals, again and again, higher cost does not always translate into better outcomes or improvements in other quality measures. Sometimes it just means a nicer looking building. So we agree with the board and the staff that at this time it does not make sense to proceed with the quality adjustment. Thank you.
Thank you. Seeing no hands raised and no one at the podium, that concludes public comment on this item.
Thank you very much, and appreciate, again, the team's work on those presentations and continued discussion. Thank you. Thank you. We are going to move on to item 5D, the spending target enforcement, continued spending target penalty discussion. Welcome back, CJ Howard and Vishal, to take us through this item.
It's good to be back. I missed everybody. Everybody had a good lunch. My name is CJ Howard. This is Deputy Director. We will continue our discussion on spending target penalties. So I'll begin by reviewing a few items from prior discussions on spending target penalties. At the April 2026 Healthcare Affordability Board meeting, OCA began conversations on spending target penalties. At the August 2026 meeting, the board may vote to approve the scope, range, and justification factors for penalties. Spending target penalties would be assessed when an entity fails to meet the spending target and has not complied with an approved performance improvement plan. The spending target penalty should provide an incentive to implement the PIP and come into compliance with the target. Per statute, it should be initially commensurate with an entity's failure to meet the applicable target and be adjusted after consideration of penalty justification factors. Next slide. At last month's board meeting, OCA recommended the following approach to calculating spending target penalties. the two-step process. In the first step, OCA would calculate penalties that are initially commensurate with the degree to which an entity exceeded the target. Initially commensurate, meaning the difference between an entity's actual spending growth and what the growth would have been had the entity met the target. If 2023 had been an enforceable year, initially commensurate penalties for some of the plans that we had collected data for could have ranged from between $4 million and $350 million. Then in step 2, OCA would consider a variety of penalty justification factors that could result in an increased or decreased final penalty amount. We'll be discussing these factors in a later slide. So that covers what we've discussed on the topic of spending target penalties in prior meetings. And on the next slide, we have questions for today's discussion. So the topics, 1, what year or years would OCA assess a penalty when an entity fails to implement their performance improvement plan and fails to come into compliance with the applicable spending target? And then what should the penalty justification factors include? But before we get into the first question, we do want to cover some future discussion items, just to make note of what we'll be returning to the board with. So OCA will return to the board in June with the following, to address the following questions. What should the range of spending target penalties be? In other words, the maximum and or minimum. What should penalties for violations described under 1275025H1 be? Can OCA assess penalties if an entity does not meet their mid-performance improvement plan milestones? And a summary of OCA's recommendations for penalties, scope and range, and justification factors for the board's discussion before a potential August vote. Okay, so returning to the first question, our first topic is what year or years would OCA assess a penalty when an entity has missed the target and has been subject to a performance improvement plan, but then fails to implement that PIP and fails to come into compliance with their applicable spending target? OCA proposes that we would assess a penalty against the performance year that prompted the progressive enforcement process or the performance improvement plan. Entities could be required to implement a PIP for each year of non-compliance with the spending target. This means that there is a possibility that entities could implement multiple PIPs simultaneously if they exceeded the target for multiple years consecutively. This approach ensures that entities are incented to comply with the target for each performance year, as OCA would assess penalties as part of the progressive enforcement process for each year an entity exceeds the target. At the end of a performance improvement plan, OCA would determine whether the entity came into compliance with its applicable target and whether the entity complied with the performance improvement plan. And the next slide will provide a visual of this. So this slide shows what we described. OCA would enforce the performance year individually, would enforce each performance year individually or discretely. We have the graphic showing annual enforcement. The dates here are approximate and for illustration's sake to show that how PIP durations may vary. Additionally, the actual start and end date of the PIPs may vary, but the takeaway is that an entity may potentially be subject to financial penalties for each year of non-compliance with the spending target. So looking at the first row, we show 2025 to 2026 spending. Let's assume that the entity exceeded the target in performance year 2026. That data is not reported to OCA until September of 2027. OCA would host our payer previews in the following months and assess performance against the target. And if ultimately, if OCA had determined that a PIP would be implemented, that would be developed in late fall, winter of 2027 until the spring of 2028. Again, these dates are by way of example. The actual implementation timeframes would likely vary. This would include the time entities have to develop the proposal, the time OCA needs to review, discuss the proposal with the entity, obtain input from the board and other regulators. And in this first row, we assume here, just again, as an example to provide context, that this is a 2.5 year long PIP that would begin in July of 28 and end in December of 2030. If at the end of the PIP, well, certainly at the end of the PIP, OCA would determine if the entity was compliant with the PIP and whether the entity came into compliance with the spending target. If they were not compliant with the PIP and did not come into compliance with the target, then a penalty could be assessed. This wouldn't happen in this case, given that there was a 2.5-year PIP until 2031, but it would be rooted back to the amount by which they missed the target in 2026. In the next year of spending from 2026 to 2027, so draw your attention to the second row, this could be the same entity. This could also just be an entirely separate entity, just showing that each year would be enforced separately and each year would have an opportunity for redress by way of progressive enforcement through the PIP process and an ability to come into compliance with the target as outlined in statute as a requirement prior to any assessment of penalties. So in 2026 to 2027, we see this a similar process play out. In this scenario, we've modeled it out where the entity misses the target and there's a 1.5-year long PIP. And here, if we assume that the entity was not compliant with the PIP and they did not come into compliance with the spending target, then a penalty could be assessed for 2027. And the same thing could happen in each year. And again, this could be one entity that missed the target 3 times. These could also be seen as 3 separate entities and how progressive enforcement could unfold for each performance year.
Can I just clarify, CJ, though, the penalty assessed cell for each of these year examples would be a single year? That's correct. Okay, just wanted to confirm that.
But so each year, though, that an entity misses the target, provided that they were required to implement a PIP, they could be held financially accountable for each year that they miss the spending target.
To use the first row, is 2031 a single year or multiple years combined?
In 2031, in the first row,
Yes.
let's say that, so they missed the target in 2025 to 2026. They were on a 2.5-year long PIP. That's what was agreed to. They're still required to meet the spending target in 26 and 27 and 28. However, in order for us to assess penalties, we need to provide an opportunity for them to implement a PIP and come into compliance with the spending target in a subsequent or future year. And so I think maybe the easiest way to think about this is one entity that has missed the target in each of these years. There's a potential that they could have a commensurate penalty for each of those consecutive years, provided that in each of those consecutive years, they did not implement the PIP and did not come into compliance with the spending target.
Is there any scenario where the penalty would be higher than 6 years of exceeding the target? Like the cost benefit analysis, like if you have 6 years of, let's say 6% growth, would a penalty ever be more than that?
If I'm understanding you correctly, we'd be the penalty in the first row is for the 2025 to 2026 for exceeding that target. So if they did exceed the target in subsequent years, we would treat each year by itself. Yeah. So they could still be on the hook for penalties for not meeting the target in 2026 and 2027, provided that they've failed to comply with the PIP and exceeded the target for applicable subsequent or future target years.
I think I understand that. I'm just questioning the size of the penalty. I can't imagine would outweigh the cost or the benefit to the hospital of not meeting the targets.
Yeah, for
health 6 years.
For healthcare entities, it followed that two-step process. Initially commensurate is kind of dollar for dollar, and then the step 2 would be the adjustments. That are required under statute. Yeah.
Thank you for the presentation. A couple of things I think we talked about the last time in terms of, let's just take that first year as an example, that the PIP, even if it was a 2.5-year PIP, we could put milestones within it. So if they were not meeting the milestones, essentially they would now be out of compliance with the PIP. Like we don't have to wait till the end of the 2.5 years. Is that correct? That's why I recall our discussion was that we could actually put interim milestones.
Deeper discussion of that. I think there's some reason to let the PIP fully unfold. Again, it's not as though while we're waiting until 2031 to see how the PIP plays out, they're still on, the entity is still accountable for meeting the target in 2027 and 2028.
That's true, but I'm also saying is that we have a two and a half year PIP in this example that doesn't look like, and I would presume obviously you're working with the entity to develop the PIP and the milestones, that the milestones would be indicating they're making progress toward. It'd probably be more process than outcome, that likely, but that they're making some progress. And if we don't have to wait 2.5 years when it's clear they're not making progress, right? Like we have a plan, we agreed to the plan, and they're not really looking like they're taking it very seriously. We don't have to wait for 2.5 years to tell them, hey, by the way, you're not taking it very seriously. We can actually go and say, well, you didn't meet these milestones. You are now out of compliance with the PIP. You don't have to wait till 2.5 years. That's why I recall our discussion. I guess that will maybe a future discussion, but one, in terms of timeline, and yes, I agree that is for that 1 year. I just want to try to clarify that we don't have to wait until 2031 if the entity does not appear like they're acting in good faith and pursuing the PIP, right? So that's number one. Number two, the other question I have, and again, you tell me if we're going to park that discussion for a future time.
Yeah, we're going to bring that back to the board in June.
All right. Okay. All right. The other thing then is that let's assume these are all the same entity, right? So now they've also didn't meet the 26-27 target. They come to the PIP development. Now, this is an entity that already has a PIP, right? So I guess, and then maybe this is again a future discussion. So do we do a PIP amendment? Do we do a brand new PIP that is probably going to still include many elements of the first PIP, et cetera, right? So how does that PIP relate to the other PIP? And then in the evaluation of whether they met the second PIP as well as the first PIP. So I want to think a little bit about that too. And again, it's back to, if they're not making sufficient progress on the PIP, then, I get it, you get some dialogue about why that's happened. But if it doesn't look like someone's acting in good faith, we don't actually have to wait all the way to the end before we do something. Like we can declare that they're out of compliance with the PIP before the end of the PIP per se, I guess is going to be. But how does the second PIP relate to that first PIP, including its assessment of whether they are meeting the second PIP? Is that an independent assessment of the evaluation of whether they're meeting the first PIP? So, let me throw it out there.
It would be a new PIP.
There could be some overlap.
There could be overlap.
Activities and the goals are. I think the issue is with each PIP, we would want to do a root cause analysis of what led to the excess or overspend. And so there very well could be differences in terms of what is contained within each PIP.
Well, it's true. It could be differences. It could be for the same reasons. I mean, it's only 1 year. So, it depends how dramatically the entity would have changed in 1 year. I mean, hopefully they have made some change. That's why we put the PIP in the first place. But my guess is that there's going to be a lot of overlap.
And to ensure, sort of just to operationalize this from an enforcement perspective, it would be, I think what staff is suggesting would make the most sense is that these would be two discrete PIPs, and we treat each year discreetly or individually.
Okay. All right. I appreciate that interpretation. I think we probably should do a little thinking about how that operationalizes. I get the idea of saying that they're two discrete plans, exactly how they're interlinked or not. I think it's going to be a little challenging that they're not interlinked in some way, even if we just wrote them as two very separate plans. Because it's the same entity, right? And whatever drove them to not meet the target the first time, probably there's still factors in why they didn't meet the second time. Maybe something new's happened and there's something, but my guess is that there's still going to be some things. Maybe I'm wrong. Okay, thanks.
Free to continue. Those were just some clarifying questions along the way.
So I could continue to the next section, which is penalty justification factors. So we're asking the board for input on, what should the penalty justification factors include. We've included a relevant excerpt of the statute describing existing penalty justification factors. So this is from section 12750.2.5, subdivision D, paragraph 6, which is that the director shall consider all of the following to determine the penalty. Here we have nature, number, and gravity of offenses, the fiscal condition of the entity, along with a number of different ways of looking at fiscal condition, and then finally the market impact of the entity. So at this time, OCA is not recommending additional penalty justification factors. On the next slide, we'll show how the factors listed in statute can cover a variety of factors. This table here shows the factors from statute in the left column. And then in the right column, we have a non-exhaustive list of potential examples of what each factor can include on a case-by-case basis. So going into the first row, we have nature, number, and gravity of offenses. So some examples of factors that could meet this statutory factor are excess growth beyond the statewide average or state average, or the spending being an extreme outlier. Another one could be conduct that resulted in harm to public, patients, access to care, affordability, et cetera. We could look at the history of exceeding the target, and then also excess growth due to investments in primary care. And then moving on to fiscal condition, some examples include bankruptcies or other legal proceedings, whether the proposed penalty negatively impacts the entity's financial standing, if the entity's revenue, profit, assets, et cetera, significantly increased, especially in comparison with other years while exceeding the target. And then lastly, for market impact, this could include some examples such as if the entity's share of total covered lives statewide is significant or greater than the statewide average, the entity's impact on spending in its county or covered California rating region, if the entity plays a unique or essential role in providing care to underserved populations. And again, just to remind the board and the public, this is a non-exhaustive list. Next slide. So again, OCA does not recommend additional penalty justification factors at this time. Some reasons for this are that the existing penalty justification factors listed in statute are broad enough to cover a wide variety of factors. And then just an acknowledgement of the enforcement considerations. So those are used to determine whether an entity proceeds further in enforcement. In determining a penalty amount, the nature, the factor listed in statute, the nature, number, and gravity of offenses, this would allow OCA to consider relevant factors that are included in enforcement considerations. And then lastly, we note here that the board can add factors later if the need arises. And then moving on to the last question for today's discussion is whether the penalty factor justification factor should be further defined. We recommend that the factors listed in statute do not require additional defining. OCA should maintain broad language to avoid forcing a one-size-fits-all structure onto a diverse group of healthcare entities and diverse situations. At the April 2026 board meeting, approaches to market impact were discussed. OCA could consider various approaches to market impact that could increase or decrease a penalty amount, including but not limited to an analysis of market power and competition, how the size of a penalty would positively impact a market by deterring future non-compliance, how the size of the penalty may negatively impact an entity's participation in the market, and any spillover effects on the market. Next slide. So now we're looking for discussion from the board. I want to note that this slide has a green arrow indicating this is an item for the board's decision making and inform a future vote of a vote by the board to approve penalty justification factors along with the penalty scope and range. So we're asking, does the board have any initial feedback on penalty justification factors as we listed? Those that are under statute on a previous slide.
Thank you. And I just, because we had some discussion, interrupted your presentation, I just want to make sure that we're answering both this question that you see on the slide here, but also the first question, which is, again, what year would OCA assess a penalty when an entity fails to implement their PIP and fails compliance? So we're answering both questions for any additional feedback to staff on those questions, board. Rick?
On the second question, I don't have any feedback other than to say the recommendation seems reasonable. On the first question about timing, also seemed reasonable. I'd like to revisit a discussion that I think we've had at least once, maybe twice, which is that if a covered entity greatly exceeds the target, say, 12% increase in a year where the target is 3.5%, and then enters into a performance improvement plan and complies with the performance improvement plan, then there is no penalty. The entity has had that year of 12% increase. My question, which I know I've asked before, but do not remember the answer to, is whether the performance improvement plan itself can require the entity to have a lower than target rate of increase in the years of the PIP. That is, to be able to recover some of the money that was spent in excess of the target in the year that triggers the PIP.
Yeah, that's something that we're going to come back to in June about the board had a meeting discussed last month about whether different targets could be established through the PIP process. So that's something we're looking into. We'll return to it next month.
Thank you. I realized that then I didn't remember the answer because there wasn't an answer.
Ian.
Could I just clarify, could I just jump in? Could I clarify the notion that a covered entity wildly exceeded the target, implemented a PIP, was put on a PIP and implemented the PIP and didn't reduce their target, they still wouldn't be penalized? Is that what I heard? The purpose of the PIP is to get people to come into compliance, not to comply per se, just for the PIP.
Yeah, in order for a penalty to be assessed, they would have to not comply with the PIP and miss the target. So they would need to have both.
And miss the target.
Yes.
So if they miss the target, even if they complied with the PIP, they would be subject to a penalty.
So, I mean, I think it points to how important the PIPs are in structuring the PIPs in a meaningful way. But we do not have the authority to assess penalties if we agree to a PIP and the entity complies with the PIP. So it's a progressive, it's or an and, right? They exceed the target and technical assistance and PIP, and we only reach the penalty if they do not comply with the PIP.
That would suggest the answer to Richard's question is even more important for us to discuss as a board.
It is important, yes.
Yes, that's where I was going to, but just to go backwards, I think the sorry, what was the last question? Anyway, I'm losing my train here, but to really underscore that, I think assessing each year makes sense because it gives the strongest chance of this whole framework of succeeding. And I do think it has to be dollar for dollar commensurate with minimal adjustments. We heard earlier in public testimony, an entity that went up 19% for this year and is going up 22% last year. It's on the high end of what I'm hearing, but not outlandishly so out there in the world. But if that same entity, excuse me, were to enter into a PIP and succeed in executing that PIP over the next 5 years that it takes us to get to the penalty stage, at that point, if the answer to Richard's question is no, and we only bring them back to each year's global target, by my back of the envelope math, they would be 36% ahead in spending of where they would have been if they had been meeting the target each year along the way. So it gives them a huge incentive if we're just assessing year by year. It gives them a huge incentive to blow the target in 1 year, successfully implement a PIP and come back to line. I think it's different if we can bring them back over the course of 2.5 years or 3 years, whatever it is, to where they would have been had they been hitting the target. I think that's a different world. So I think I tentatively agree with the framework here, but that the answer to Richard's question is really key.
So one of the things that we did mention in the April board meeting was that one of the things that the board could consider is adjusting targets for entities that might have had exponential growth in 1 year, and addressing it that way so that their future year targets in whatever a future year could bring them back into line that way. That is something that I think the board could consider.
Actually, I wanted to answer a question about the second part of the presentation around the penalties. So I think that because you're recommending that factors listed in statute do not require additional defining, I think ultimately we want to be sure that however we make these decisions, that they're viewed as just and fair, right? That we're not picking winners and losers, and so that's going to be a little challenging because we can try to say, well, so I hear what you're saying, like, well, the statute. I mean, we purposely also left kind of things in broad the statute because we figured that instead of trying to do it through the legislative process within, but I think somewhere there's got to be some clear guidelines in terms of what kind of circumstances will lead to either lesser or greater penalties related, because you're saying, okay, well, so for example, does a big market share lead to greater penalties because you want to send a message, or is it a lesser penalty because it's going to have a bigger impact on the market, right? And it can't look like it's arbitrary. Like we decide with this people, we like these people. I mean, maybe that's not what we're really doing, but someone's gonna say, well, you like those people, that's why you didn't hit them. But then you really hit even though there's the same circumstance. And I think that's what we want to try to avoid. We don't want to have a situation where people are trying to think that we're picking, basically we're picking winners and losers, not based on some objective criteria, but because, of relationships we may have, or relationships people may have with, people in the state or whatever else. So while I get the idea that you don't want to have additional defining, I think there needs to be upfront before we start imposing penalties, some direction as to what our direction, how we're going to make these decisions, and a greater guidance than what currently is in the statute.
Not seeing any additional questions or comments from the board. Just also want to weigh in on the second component here around the justification factors and concur with the recommendation to date. And obviously lots more conversation to be had with the questions that you added that we'll be discussing next month. So again, appreciate the work as we continue to think through this and how we're ensuring that we're not unintentionally incentivizing what we're actually trying to impact here. So just appreciate the conversation at the board. With that, we're going to go to public comment on this item.
We'll now take public comment. If you are attending virtually, please raise your hand or press *5 if you're dialing in. We will start with a virtual attendee. Cindy, I see your hand raised. You should be unmuted on our end. Please go ahead. Cindy, you're unmuted on our end. You might need to unmute on yours. We will come back around and I will go now to the individual at the podium. Please go ahead.
Good afternoon, Anate Miller speaking on behalf of the California Association of Health Plans. I wanted to briefly flag an issue for the OCA board that is directly relevant to today's to today's discussion of spending targets, enforcement, and the use of cost data in informing policy decisions. Under the governor's May revision, the proposed Managed Care Organization or MCO tax would introduce a significant new cost into the commercial market at a time when payers are already operating under OCA spending targets and heightened scrutiny on premium increases. The MCO tax will increase costs on premiums by $1.5 billion annually for employers, individuals, and families. That equates to nearly $9 per person per month. Over an entire year, it increases premiums by over $100 per person and over $400 for a family of 4. This new tax, if enacted, would take effect in 2027. Clearly, this is not aligned with the goals of OCA, which is to limit overall spending growth. Health plans are also concerned about the downstream effects this may have on market behavior, including increased pressure on affordability and potential shifts away from fully insured coverage, particularly in the employer market. Over time, this could affect the stability of risk pools that underpin the very spending targets being discussed today. This MCO tax, if enacted by the legislature, should necessitate some accommodation by OCA as the spending target is applied to 2027 cost data. More broadly, we would also encourage continued clarity around how payer cost and financial data are interpreted in this process. Discussions around admin costs and profits are often presented at a high level, but those figures include a range of required expenses, including taxes, regulatory compliance, and reporting obligations, in addition to core administrative functions. Ensuring that all these components are well understood and that cost drivers are evaluated in their full context will be important to support accurate assessments of performance and to avoid any oversimplified conclusions about what is actually driving spending growth. We would respectfully encourage continued coordination across state agencies and continued transparency in methodology to ensure that new cost drivers like the MCO tax and underlying data are appropriately reflected in the spending target implementation and enforcement process. Thank you.
Thank you. We'll look back virtually. Elizabeth, I see your hand raised. Please go ahead.
Thank you. Good afternoon. This is Elizabeth Espinosa today on behalf of the California Association of Public Hospitals and Health Systems. California's public hospitals and health systems support the goals to make healthcare more affordable. However, we have significant concerns with the proposed framework on financial penalties for spending target performance. Public hospital care systems are facing nearly $4 billion in cuts as a result of H.R. 1, changes to Medi-Cal coverage and payments that were recently enacted, as well as those now being considered through the state budget process. As a result, some public healthcare systems are contemplating service line reductions, staff layoffs, and potentially other larger changes like facility closures. The penalty structure proposed by OCA could further destabilize our systems and lead to even more widespread disruptions, including loss to access for patients. Further, many questions remain around how hospital performance against the target will be assessed or what considerations OCA will make as part of its approach to enforcement. And we're already halfway through the first enforceable year of the target. With these many unknowns, it's impossible for health systems to plan and make adjustments at the local level to try to preserve access, while at the same time avoid being penalized under OCA's policies in the current and upcoming performance years. We urge OCA and the board to consider alternative approaches to the penalty framework, similar to what has been adopted by Oregon for its cost growth target program. Additional details on this alternative approach and our specific concerns are outlined in our recent comment letter to OCA and the board, and we look forward to any opportunity to partner on developing solutions. Thank you for your consideration.
Thank you. Back to the podium.
Members of the board, staff, Steve McDougall with CFT, a union of educators, and classified professionals. Premiums, deductibles, copays are more than California's consumers can afford, as you've heard. Consumers pay penalties every day via runaway premiums, deductibles, and copays. Total healthcare expenditures should not outstrip wage and salary increases, but they do. They zero them out in many, many cases, or worse, pay cuts. I took a pay cut halfway through this school year. My premiums went up. I did not get a raise. We should follow the law, and penalties, we should follow the law in this country, let alone this state, but that's a different discussion. We should follow the law, and penalties should be dollar for dollar assessed. Billions, certainly hundreds of millions, if not billions in reserves built on our backs should not be preserved or increased or maintained by excessive provider prices. No. Those need to be in the rearview mirror. And lastly, we absolutely should shed light on bad actor provider entities. Consumers should know where we're taking our healthcare dollars. Thank you for listening. I'm going to get on the road. Take care.
Thank you. Looking back virtually, Cindy, I see your hand raised now. Let's try it again. We'll unmute you on our end.
Thank you. I found the unmute button. Can you hear me now?
We can. Thank you.
Great. Thank you. Thank you so much. And thanks the board and the staff today. It's been an interesting discussion. My name is Cindy Young, and I serve on the board of directors for the California Alliance for Retired Americans. We represent over 1 million elderly and disabled Californians. And our concern particularly is for workers in that 55 to 65 age range. We are seeing, because we access the system more when we get older, the chassis gets rusty and we have to get in and have things taken care of as we get older. And so our premiums are often much higher than they are for younger working adults. And we have seen premium increases from 15 to 20 to 25% at the very time that we are trying to prepare for retirement. So we're trying to save, we're trying to get ready to retire. Gasoline is going up, rent is going up, groceries is going up, and our healthcare premiums are excessive. And we are paying that penalty right as we're getting ready to retire. So I would urge the board to, to consider the penalties. I don't think we can back off on them. They will absolutely help healthcare premium increases stay in line, since 40% of what we pay are hospital costs. We absolutely think this is important, and thank you much for letting me weigh in today.
Thank you. To the podium.
Hi, Ben Johnson from the California Hospital Association, here to share questions and concerns on OCA's recommended penalty structure. We dive deeply into many of these issues in our letter, which is published as part of the meeting materials. First, OCA's proposed framework here would impose extraordinarily high penalties that would put hospitals out of business. Penalizing hospitals at their overage would result in penalties that could start at well over $100 million for many hospitals, large part due to volatility year to year in their spending growth. For 117 of the state's hospitals, the starting penalties would come to amounts that exceed their cumulative operating earnings from the prior 3 years. And the proposal is a major outlier compared to other states, where the starting penalty in California would be 20 times higher than in Oregon, which phases their penalties in based on repeated violations of the targets. And it's only through large and unpredictable downward adjustments that OCA could reduce them to practicable levels that don't endanger access to care. Adjustments, as discussed, to the penalties in any framework are essential for OCA to realize its mandate and prevent unintended consequences. And the penalties cannot ultimately undermine hospitals' ability to remain viable. So for this reason, we've urged OCA to adopt a cap on penalties at a hospital's patient care earnings. It's concerning that OCA appears to be backtracking on prior commitment to account for other factors in adjusting the penalties, especially when it continues to recommend penalties that start at such enormous amounts. This would mean an entity's progress in reducing its spending growth would not be accounted for in the penalty. that the effects of new state mandates or federal tariffs, MCO tax in this instance, wouldn't be accounted for, and that efforts to invest in patient-centered and often preventive care would be disregarded. This is not what the legislature envisioned in laying down a framework for collaborative pursuit of the goals of promoting access to high quality and affordable care. Our letter further outlines the need and statutory directives for OCA to provide meaningful opportunities for healthcare entities to improve their spending trends before financial penalties are imposed, and look forward to that discussion at the next meeting. And then finally, hospitals are concerned that the end of the very first enforceable spending target is roughly a month away for over 100 hospitals with fiscal year ends in June 30, and yet hospitals do not have clarity on how their spending will be measured. We raise very specific issues in the letter, including the extraordinary volatility in annual growth figures that do not correspond in at least a single year-to-year period with the unit price growth metric that OCA aims to measure.
3 minutes.
Hospitals are not receiving 50% growth or cuts in their Medicare spending, and yet such growth rates are very common in the data. This volatility really necessitates, unlike what was discussed today, multi-year measurement of hospital spending growth. Further, OCA has stated it will measure payer and service lines separately against the targets. If growth in any payer service line triggers enforcement, at least when back applied to 2022-23, it would mean that 92% of hospitals would have been above the 3.5% target for at least one payer line. So we recommend only enforcing targets against entities that exceed their targets on both their all-payer and commercial lines, and either combine inpatient or outpatient into a single measure, or enforce only against hospitals that exceed on both of those service lines. So thank you for the additional time to address a number of concerns, and look forward to working with the board and the office to address these moving forward.
Thank you. Looking back virtually, Neil Clark, I see your hand raised. You should be unmuted. Go ahead.
Yes, thank you. This is Neil Clark on behalf of the United Hospital Association and its member hospitals. Thank you for the opportunity to comment today. Hospitals share the goal of improving affordability for patients, but the enforcement framework must be workable, balanced, and grounded in real-world conditions. State law envisions a meaningful, collaborative remediation process, not punitive measures that jeopardize access to care. The proposed penalties are far beyond what other states impose, and for some hospitals could exceed operating margins from patient care. At a minimum, enforcement must account for financial condition, factors outside a hospital's control, and reliable multi-year data. Californians need an approach that advances affordability while preserving access to hospital care in every community. Thank you.
Thank you. Looking back to the podium.
Beth Capel, Health Access, California. Health Access supports the OCA board setting the scope and range of penalties consistent with California law, which requires commensurate dollar-for-dollar penalties. Using OCA or using Oregon or Massachusetts law lacks statutory authority under California law, and said more simply, is contrary to California law. We appreciate that penalties are at the end of an exceedingly long enforcement process, and it is the final step, which we hope is never reached, because we hope entities will comply with the targets. We note that most hospitals, in fact, according to the data we've seen, would in fact comply with the target of 3.5%. And indeed, the Hospital Association's own letter, try not to, notes that some of the penalties would be, many of the hospitals would face penalties of less than $1,000. So that seems to us somewhat modest. OCA has published its methodology for reporting hospital spending, as well as the data submission guide for plans and insurers. Both hospitals and health plans and insurers will be measured using their own data. They will know in advance whether they have exceeded the targets or not. I want to echo what Steve McDougall said. Consumers pay a penalty every day, and high premiums, and every time we go to the doctor or pick up a prescription or get a test. We've been through the survey data time and again, it's only getting worse. How can we be in a world in which healthcare in California is less affordable than housing in California in the view of most Californians? How can we be in a world in which people are going without food to pay for healthcare? That's wrong. With respect to the factors for penalty justification, and again, we hope we never get to a point where we're imposing penalties. We hope that the other steps in the enforcement process, including enforcement considerations, avoid that. The one thing that the staff did not focus on, but that we will mention again, is that fiscal condition does not just apply to the individual entity. We started off the day hearing from Providence. This is a very large enterprise with 17 hospitals, 250 clinics, and over 10,000 medical staff. The law gives the director the authority to look at the entire enterprise, not just at an individual hospital or large physician organization, and not just at the insurer or health plan. And we think that's essential to fair enforcement. We will also note that in terms of objective criteria for enforcing penalties, we have some time to work on that given the long timelines for implementation. Thank you.
Thank you. Looking back virtually, I've got a hand raised under the name Anonymous. Please go ahead. We are unable to hear you on this end. You might need to unmute on your end. The unmute button should be in the top right-hand corner. We'll give you a second. All right, I'm sorry, we are not able to hear you on this end. Give you one more moment. You're unmuted on our end, so it should be a button on your end. All right. Another opportunity, if it's not working on the Teams interface, would be to dial in, and the phone number is listed on today's agenda. And when you dial in, you can press *5, and that would be another opportunity to raise your hand. You can also submit comments to the email address provided on today's publicly posted agenda. That concludes public comment on this item.
Thank you very much and appreciate that conversation and additional staff work. We're going to move to our final informational item. We're going to welcome back Heather Hogan, Assistant Chief Counsel, for the introduction to the Cost and Market Impact Review regulations.
Once again, good afternoon. Heather Klein-Hoganson, Assistant Chief Counsel and OCA's Compliance Unit. First, I kept you from lunch, and now I'm going to keep you from going home. We all know that OCA has 3 prongs: slowing spending, promoting high value, and assessing market consolidation. And so we are now at the 3rd prong in today's agenda. The Cost and Market Impact Review Program looks at market concentration and transactions. Last summer, AB 1415 was enacted into law, and they added that legislation, added a new category of noticing entities, which are required to submit material change notices, or MCNs, to OCA for review. Those noticing entities include private equity, hedge funds, management service organizations, new entities created for the purposes of the transaction itself, and entities that control a provider. Next slide. Given that legislation, OCA needs to update its CMIR regulations. And so we've been working on that since the legislation was enacted. We've met with various stakeholders and gotten input on a variety of options we had to change our regulations to make them more responsive. Our proposed text has been placed on the website and was part of the meeting packet today. You'll note that there's a yellow arrow. That's because we're asking for your input on today's regulations. The proposed text defines the noticing entities, MSOs, hedge funds, private equity. We add a definition in our definition section for healthcare entity, or we update the healthcare entity definition. We add the hedge fund, we add the MSO, we add the noticing entity, we add the private equity group. We also add one for submitter for convenience, and we update the definition of transaction. We add thresholds and circumstances to match for those control factors. And next slide. We've updated our confidentiality process. That's based on our experiences dealing with multiple transactions. I think if you remember last board meeting, I said we've had about 45 transactions that we've reviewed with multiple submitters. We've actually pulled out the provisions. We had it in another section. We've pulled it out to its own section to make it easier for people to find, and we've expanded it. We've included confidentiality for CMIR processes as well, because those do change slightly when we move from just reviewing a notice to actually going to CMIR. And then we have heard a little bit today about quality assessments and CMS star ratings. We are proposing to add that sort of quality assessment to the public notice that goes out so that we know that if an entity or entities that are involved in a transaction have quality ratings, that's part of the public notice for transparency. We've also added real estate investment trusts. We have seen in case law as well as studies where real estate from underneath the building where healthcare is provided can sometimes be over leveraged, and those debt ratios can cause ultimately financial harm. And we've also added post-transaction impacts to collective bargaining if it is known by the parties at the time of the transaction. And those would go in the public notice. Next slide. We have also added another potential reason for an expedited review based on our experience and requests. And we've added to the decision to go to a full cost of market impact review some of those over-leveraged issues such as real estates that can cause harm. Finally, we added a remand procedure if new information comes up. The review is complete. We are making our decision to go to a CMIR, but there's actually some new information that causes us to take a second look rather than have someone, the transacting parties pay and wait for a full CMIR if there is some reason not to. Next slide. So our next steps, as I mentioned, the regulation text proposal was placed on the website, and we are accepting comment until June 11th. We would then take into consideration those comments made, update as needed, and then go to OAL as an emergency regulation. And then once the regs are ultimately approved, we of course would update our submission portal and our website with the frequently asked questions, and we are working on a new way of listing the transactions that might make it easier for people to find what they're looking for. So those are our next steps. So with that, I wanted to know if the board had any input on the draft that's been proposed.
Questions or comments from the board? Thank you very much. Seeing none, we will go to public comment.
We'll now take public comment on this item, and as this is the last item for the day, this can also serve as the general public comment period. Seeing no hands raised, I will go to the podium.
Beth Capel, Health Access California. As the sponsors of the legislation, we will look forward to submitting comment. And just to note, we appreciate the recognition that REITs can cause quality problems. Those of us who work in the nursing home space have long known this. Thank you.
Thank you. Looking virtually, they put the hand on. All right, excuse me. Harvey McKeon, I see your hand raised. Please go ahead. Harvey, you should be unmuted on our end, but we're not able to hear you yet. You might need to unmute on yours.
Good afternoon. I think you can hear me now.
I can, thank you.
Thank you very much. So one thing I think the broader healthcare workforce, and by that I specifically mean the healthcare construction workforce, would benefit from in all this discussion is the cost of responsible construction, including the cost of state mandated construction. Expanding competition in California's regional markets will also require expanded CapEx spending from market players on construction. So the reason I'm giving this comment today is I believe that at some point we do need to have a more focused discussion to guard against an unintended consequence of spending target pressures leading to standard eroding cost cutting on medical construction. As industry observers, we're not yet seeing the race to the bottom we've seen in other construction subsectors, but we are seeing some troubling signs and some market players pivoting to contractors that we consider to be irresponsible. In at least one case, this involves a major construction project, and we'll provide more details to the board in HCI on this and the implication for workers at subsequent meetings. But to summarize, there's already been discussion by this board that the spending target should not be implemented on the back of frontline healthcare workers. Construction workers also merit similar discussion and consideration by OCA and the players they regulate. This workforce is incidentally also one of the most underinsured groups of workers in the state. Any lowering of standards in this industry by the altered CapEx behavior of healthcare companies, alarmistly responding to regulatory compliance, could only further exacerbate this situation with a large portion of uninsured workers in our state. So we hope to continue this discussion. Thank you for today's broader discussion, and we'll look forward to participating more. Thank you.
Thank you. And I just want to acknowledge I do have a caller with a hand raised. You are second in line, so I will come back to you to the podium.
Well, I was going to say if it's Bianca, you can go to her. I'm making comments for her.
I do not know who it is, but I can call her. Yeah, last two digits 70. You should be unmuted. Press *6 on your end.
Can you hear me?
We can. Thank you.
Hello, Healthcare Affordability Board. I am a California patient and member of the public. Healthcare affordability is not only about what healthcare providers spend, but it is about what patients are forced to suffer, guess, and fight to understand. And when a patient cannot understand the bill, cannot identify who is charging them, and cannot get a straight answer before being threatened with collections, then transparency has already failed. And when transparency fails, affordability fails. And patients should never be punished, intimidated, or treated as a threat for asking basic billing questions. Patient safety does not end when surgery is over or when the patient leaves the hospital. It includes the right to clear records, clear bills, and clear answers. We can't call a system charitable when patients are left confused, silenced, and financially afraid. Transparency is not a courtesy, it is a duty, and it is a patient right. Patients should not have to become investigators of a medical bill. I urge this board to make affordability enforcement protect the patient's lived experience, the right to clear numbers, honest explanations, visible ownership relationships, and real accountability from the institutions that claim to serve the public. Thank you.
Thank you. Back to the podium.
I'm Katrina Walters White with Health Access California. I'm making the comments on behalf of Bianca, who was unable to join. So it says, thank you for the opportunity to share the small business perspective and why the Office of Healthcare Affordability is important to California. 4.1 million California's 4.1 small business owners. My name is Bianca, and I'm the California Director of Small Business Majority, a small business organization that empowers entrepreneurs to build a thriving and equitable economy. The authentic voice of small business is often underrepresented in public policy conversations around healthcare affordability. Larger businesses' interests tend to frame this as ideological, but the vast majority of small business owners I speak with every day want a healthy workforce. They just can't afford Facebook level of benefits. They struggle to afford quality health care for their workers or access for it themselves. This is a real policy conversation. Half of ACA enrollees are small business owners or employees of small businesses. Recent small business majority research released in November 2025 found that 2/3 of small businesses say rising healthcare premiums are a financial burden on their businesses, with nearly half describing those costs as a major burden. As a result, 51% of small businesses have increased employee contributions to health plans, 47% moved to plans with more limited coverage, and 29% cut their employee benefits. Our polling also shows strong support for policies that lower costs through transparency. OCA's work is critical because it collects hospital spending data, sets cost targets, and that help keep healthcare affordable for small businesses, and provides oversight of healthcare consolidation that drives up the prices without improving value. Last OCA hearing, SBM's Small Business Majority shared their experiences. Today, I'd like to share the words of one California small business owner, Han, owner of Studio in Rancho Cucamonga. We're a very modest operation, and I try best to compensate my team fairly while also running a business that's able to stay afloat. I'm constantly thinking about my margins and cash flow, so affordable healthcare is extremely important to me. They shared that healthcare costs now account for roughly 7 to 8% of his business expenses, in addition to vision and dental coverage. He also explained that health insurance is crucial to recruiting and retaining talented workers, but it's difficult for small businesses like mine to afford it. I want to expand my team and hire new employees, but the increased cost of healthcare coverage makes me very hesitant to begin hiring. His story reflects many entrepreneurs throughout California and what they're facing. The board has an opportunity to make healthcare more affordable for tens of thousands of low and moderate income entrepreneurs and small businesses employees by setting spending targets grounded in real consumer wages, not just economic growth. Without OCA, insurers and hospital systems will continue to increase costs without adding value for consumers, leaving entrepreneurs with less to invest back into their businesses and their communities. Thank you again for your time and listening to the needs of California's small business owners.
Thank you. Looking virtually, Harvey, I can see your hand raised. Go ahead.
Yes, sorry, just quickly for the record, I forgot to add that I was speaking on behalf of the North Coast States Carpenters Union. Thank you very much.
Thank you. Back to the podium.
Hi, Ben Johnson from the California Hospital Association. Thank you for the opportunity to review draft emergency regulations and for the presentation today. These regulations, as we know, are really intended to implement AB 1415, but following our preliminary review, there are several ways where we think they diverge from the intent of that law. First is that the regulations expand the definition of healthcare entity to include entities that no longer, or that own providers that no longer are operating or have a suspended license. However, under state law, That expanded definition, or at least that authorization, only occurs under the definition of noticing entities, which are submitters but not more broadly regulated by OCA. And so we ask for changes to conform with the law there. Second, draft regulations add major new reporting requirements on top of the extensive ones that are already in place. And these will add complexity to the reporting and the reviews and slow the process, ultimately and potentially discouraging transaction at the same time as new waves of closures and severe distress are coming due to the One Big Beautiful Bill Act, and in which transactions with other entities may provide a lifeline. Third, would like to understand better the definition of management services organization and understand better how it conforms to the law. And then finally, AB 1415 included a commitment to reduce duplication in noticing and reporting to the office within this process, and those provisions appear absent from this regulation. So look forward to working with the office and board on these going forward, and thank you very much.
Thank you. Looking virtually, seeing no hands raised and no one at the podium. That concludes public comment on the last agenda item and also our general public comment period.
Thank you very much. Just again, appreciation for all of the staff and team who put together the materials today, but also to the public who engaged in this process in our joint objective on healthcare affordability. Before we adjourn, I neglected to give board members an opportunity to say a few parting words, given that this is Board Member Mitchell's last meeting. So I wanted to not leave without that opportunity.
Well, if I could, Elizabeth, you have come to this board with optimism, clarity, conviction, and I, for one, wish you well in what you're going to do, and will channel you in every opportunity I get. And with that, I wish you all the best. It's been a pleasure to serve with you on this effort at this time.
Yeah, you all probably know it's very rare for me to say something positive about somebody who leads an organization of big employers, but it comes easy in your case. No, between working people and the entities that employ them, we pay for near half of all health spending, not even counting the taxes. And yet too many big businesses just see that as a line item to manage on their expense statement. And I have seen you do your person's work to shift that mindset. And it's clear it's not just about pursuing good value. It's because you really get that healthcare is a lifeline to people and that these cost barriers are a threat to people's lives. And I deeply, in a very heartfelt way, want to express my appreciation for what you do in the world. Thank you.
The labor management profession.
I also express my appreciation, and I have learned a tremendous amount from listening to you over the last few years. And I'm reminded, actually, my first job in state government was in Massachusetts Medicaid program, and I worked for a budget director who was infamous for saying, "What part of zero do you not understand?" And I am reminded of that in having learned from you over the last few years. Best of luck. We'll miss you.
Best of luck, board member. And we think it's safe to say there'll be some references to you as your legacy continues in the work that you've embedded in this board. So thank you, and we wish you the best. And with that, we will adjourn. Thank you.